Hi, good morning, students. My name is Dr. Elisa Alvarado, and I'm the director of the PATS program at Region 1. First and foremost, I'd like to welcome everyone to our healthcare conference. And I'd like to take a moment to thank our sponsor, DHR Health, who always goes above and beyond to help our community. In the conference today, we're going to have two participating school districts, Vanguard Academy and South Texas ISD. Welcome, students. What we would like to do today is take you through an array of different pathways in health science. You're going to hear from different professionals, and I'm also going to get to do an interview with Dr. Skoobish, and you're going to love it. So I want to take this time to tell everyone, please keep an open mind and know that everyone has a different pathway, and there are so many options in the healthcare science field. Thank you again for joining us today, and on behalf of Region 1 and DHR Health, enjoy your conference.
Hi PATS students, my name is Robin Dominguez and I am one of the interns working on the PATS project. If you haven't already, don't forget to check out our website at www.patscentral.org. This website is created specifically for you and now includes our new Allied Health portal. If you also have little brothers or little sisters, we also have a middle school and elementary school portal. Thank you for listening. Bye.
The Rio Grande Valley, Texas. 1990 population, 450,000. In 2018, it was over 1.4 million and rapidly growing. For decades, South Texas lacked critical access to healthcare services. With the dynamic growth of the region, there was a mounting need for better healthcare. In 2003, local physicians came together to create a full-service general acute care hospital to meet that need. DHR Health, rising for you for life.
Carlos Cardenas, Chairman of the Board, Chief Administrative Officer. We are an acute care hospital that is open 24/7, 365 days of the year. We built this hospital so that we could be the very best physicians we could be. We were able to remove the impediments that got in our way that kept us from doing the things that we knew how to do. DHR is managed by the same physicians who deliver the care at the bedside in our hospital. We put the patient at the center of everything that we do.
It makes me a better physician to be able to work in a facility where every member of the healthcare team feels empowered to make the very best decisions for their patients. It's done that way here every single day, every time.
My name is Robert Martinez. I'm the Chief Medical Officer and Chief Physician Executive. So in the beginning, when we were working, most of us were out-of-town corporations, what we found was we were really having problems getting the things, the resources we needed to best care for our patients in the hospital.
Patients were denied the sophisticated services that were available elsewhere. Physicians were denied the means to treat the patients in the manner in which that they were trained to do so.
A particular instance I remember is when I had a really sick patient with abdominal pain, severe abdominal pain. I needed a CAT scan, I needed it quick, and I think there was a refusal of the administration at this particular hospital to hire the appropriate staff and have the appropriate equipment to be able to get that test done. That made me realize there was a problem.
At the same time that tens of millions of healthcare dollars were being taken from the community and shipped to out-of-state corporations.
So when you see an example like this, you really have to ask yourself, who really is benefiting from this healthcare? It sure wasn't the patient, and it sure wasn't the physician.
When I was growing up, we had to travel outside of our area in order to be able to get similar care to what we can provide here today. We had to travel to Houston, 350 miles away. We had to travel to San Antonio, 240 miles away.
The Valley has always been so isolated, both in terms of healthcare and economics.
I'm Dr. Bertha Medina, and I practice obstetrics at DHR Health Women's Hospital. We live in one of the poorest counties in the United States, and I think a lot of our patients don't have access to health care, perhaps until very late in their lives.
We decided to leave the old paradigm and create a new way to deliver health care, putting patients at the center of what we do, where the same physicians that care for our patients are the ones who manage our hospital and make the choices and decisions that deliver the highest quality care to the patients in our community.
DHR Health represents a unique model of medicine, where physician leadership, the latest medical technology, and a keen understanding of the community are paramount for delivering world-class health care for South Texas. DHR is majority owned by the same doctors who treat patients every day. It's not a new idea. Historically, doctors would own hospitals. But over the years, corporate healthcare took greater control of hospitals, and the gap widened between doctors and their patients. More layers of administration bureaucracy were getting in the way of patient care.
Who better than physicians to be making choices and decisions about what equipment we should have, what nursing staff ratios should be, how a facility should be managed?
As doctors, we're at the bedside of our patients. We know firsthand what they're experiencing. If we have any difficulties with their care, we can take the problem to the boardroom and immediately resolve their issues for the betterment of their care.
Many hospitals, I think, in our country are run by out-of-state corporations. They answer to Wall Street. We are a community-based hospital that answers to Main Street.
It's all about the patient and the community you serve. If you're true to the community will be true to you.
Here in South Texas, we are the trendsetters. We are the trailblazers. DHR Health is a hospital that is being innovative in the delivery of healthcare.
Physicians want to help people. They dedicate their lives to alleviating suffering and pain. A physician-owned hospital? Well, that's a label. This is a hospital that is built for the community. This is a community hospital. DHR Health, rising for you for life.
Good morning, PATH students, educators, and parents. My name is James Kurtz, and I am the Senior Vice President of Education and Employee Development for DHR Health. And on behalf of DHR Health, welcome to our virtual conference. We are happy to have La Jolla ISD, South Texas ISD, and Vanguard Academy joining us today. We, here at DHR Health, are excited to have you with us today as we bring to you a bit of insight on healthcare and the careers you're likely to find within our hospital. This conference will showcase several of our healthcare professionals who will share with you their path into healthcare and what is it that they do to help our community. The need for healthcare heroes has skyrocketed in our region, and we need students like you to join our team in making a difference in the lives of others. So, for all of those students joining us today, we hope that you gain some valuable insight to what healthcare workers do and how every path is different, but ultimately gets you to be that change maker in our community. So, sit back, relax, take a big breath, and enjoy. Also, be sure to take lots of notes. We'll see you soon. Thank you.
Welcome, PATH students. My name is Dr. Jorge Montes, coming to you from the DHR Health Eye Institute. I would like to share a little bit about how I got here and how my career kind of came to be. So first, most doctors actually have a very similar foundation, all of us. And then we deviate based on what we want to do. So I'd like to share with you how I actually came to my clinical pathway, but just keep in mind that the first portion of what we do is very similar in any specialty that medicine has to offer. So first, the good foundation to anything is going to college. So obviously before that, you have to finish high school, get your diploma. The big next step is college. Even recently, college has been one of those things that has come to question as to whether you need to do 3 years or 4 years. Many people do end up finishing just 3 years as long as you have enough credit hours to proceed and to apply to medical school. But for the most part, most people will decide, since you put that time and that energy into actually finishing the 3 years, you don't want to finish and not have a degree. So most people will take those 3 years and actually finish off the next year so that they can not only have their medical degree, but also a bachelor's degree. And it does not matter whether you get bachelor's of science or bachelor's of arts, or just a bachelor's degree would be sufficient. A lot of questions come from whether you need to get a science-related degree, or can you do a liberal arts degree, a political science degree, or any of those degrees. And honestly, I did get a science-related degree, but standing here now and looking back, really any bachelor degree should be sufficient as long as you have a core requisite, which is a standard that everybody should look into. A couple chemistry classes, some organic chemistries, but if you can do that along with any other interest you may have, it would be nice. Thinking back, I probably should have done things that interest me more than this science, but at that time I was focused on the goal at hand, which was to become the best science student that you could be, but that doesn't have to be the case. If you have a passion in arts or anything else, you can get your degree in what you're interested in. Medical school, even more so nowadays, starting to look at very well diverse applicants. So the applicant pool, making yourself diverse. So having that unique separation between you and the next person. So maybe having an interesting background in economics, which is also really important in the field of medicine. But after you get your bachelor degree, the next step is medical school. And this can seem daunting. This chart here can seem very daunting, but then the very next step is another 4 years of medical school. And this will be the last 4 years that you're going to pay to be getting trained. College, you have to pay to go to school. Medical school, you have to pay tuition. But after these 4 years, thereafter, although there's still more training to do, you'll be paid something. At least you're not having to borrow more. And so I think that even if we just take a moment to stop here, this at the end of this career is what's daunting, because you have the 4 years of college, 4 years of med school, and some people think that 8 years is too long. But through my own personal experience and through having seen, my own friends go through similar different career changes, I've realized that even at the end of those 4 years, when I was finished with med school, after 4 years of college, there were still a lot of my friends that were still kind of bouncing around their first couple jobs. And by the time that they're done with their second job, maybe 2 years at one site, 2 years at another site, you'll be done with your medical degree. And that would be very, very, the MD degree was something that I think by that point in time was very stable. So at that point, I had a lot of friends that were already stable into some careers, but some were still jumping around. So I don't see it as a negative, other than that I had to pay for, I didn't earn income during those 4 years. But don't let the 4 years of college, 4 years of med school be something that prevents you from doing it. As long as you don't stop halfway and decide to change at that point, because you'll have a lot of debt and student loans. But thereafter, after med school, you have to do an internship. At least to, now speaking more specifically, this is where we draw the line between all doctors. All doctors have to get a college degree, and all doctors have to get a degree from a medical school. there are two big types of medical degrees that physicians use, and that's Doctor of Osteopathic Medicine, and then that's a DO, and then you have Doctor of Medicine, which is the one that most people know about as an MD. And then here in the United States, they're equivalent. The testing's the same. It's just a different approach to how you're going to treat your patients. Here's where I decided to move on and do more specific training towards what I'm doing now, mainly eyes and eye surgery. And so I started off with an internship, which was 1 year in internal medicine, which was a paid internship. And then I did thereafter 3 years in ophthalmology residency. So that's already putting you at about 12 years after high school, which again seems daunting, but really once you start your internship, it's like your career now. You're practicing medicine. This is what you're going to be doing the rest of your life. So don't look at it as further schooling. It's just more training. That it's already the start of your career. But things that have to be done in order to actually start practicing in your subspecialty. So since then, at least personally for me, I've been in practice almost the full 7, going on my 8th year now. So that's about where I'm at in my career path. So practicing for 7 years. And let me tell you, it goes by way too fast. Looking at this personally, I did go to Texas A&M for my undergraduate. I got a bachelor's in biomedical science, which again, going back to the beginning, does not have to be in science. But, you know, I wish I would have learned a little bit more about political science, more about finance, because those things help you in life too. But I skipped all of that because I was so focused on science. So I think going back, thinking about personal growth, probably making myself a better person. I don't think I needed all of that science as an undergraduate degree. I could have just learned things that I would never had the opportunity to learn again. I just didn't take advantage of that. So that would be something that I would recommend if you have that. That's the time to do it, is learn what you want to learn, what you're interested in, but use that for personal growth in the future. Med school, I went to the Health Science Center in San Antonio. I really enjoyed San Antonio, but obviously there's many medical schools. Being here in Texas is very unique because Texas has the most medical schools in the entire state than any other state. So I think now they have over 8, but some states don't have any. And in other states, they just have 1 for the whole state. So we have over 8, I think now. I stopped counting, but we have many medical schools in the state of Texas. So it's nice because medical schools do prefer taking in-state students versus out-of-state students. And although Texas is big, it's still per capita, or for the amount of applicants we're getting, still kind of gives an advantage to people who are from their own state, as long as you're open-minded as to where you want to go. So that's the college and medical school. From there, I actually did my residency in San Antonio as well. And so I pretty much, after college, I pretty much stayed in San Antonio. And so I started practicing. So a big question is, how do we pay for this? So there's college, and that's 8 years where you're not making money, and 8 years where bills are due, 8 years where tuition is due. And personally, for me, I just lived off of student loans. And it does get scary because halfway through there, maybe even once you start signing the medical school loans, it gets scary seeing just these loans pile up and you don't see an end to it. I would say that I had some scholarships and grants, but for the most part, it was student loans. And I think this is one obstacle that every medical student is going to face, because most people pay for undergrad school and medical school with student loans, and if everybody feels the same. So kind of keep yourself in an environment where you're around people, how they're managing things. You really have to make the best use of every dollar you're borrowing, so that it's not you're not wasting it, and then you don't have an enormous amount of debt when you get out. But it is really reasonable to get onto a plan that will allow you to pay them off if you actually finish. So the goal is never to do halfway. The goal is to finish. So if that's your goal, then the student loans should not be a problem. I know a lot of other people have decided to work through college, some through med school, but I can tell you that it may work through college. Working through med school is not going to be a great idea. You really need to focus on what you're there to do, and so loans will be a part of the process of getting to this point in time, at least through med school. Undergraduate, if you can manage it and work through it, that's completely acceptable. So personally, talking about my experience, you know, I didn't leave home thinking I was going to do medicine. I left home. I went to A&M actually for their engineering program. I finished my first year there. It was a really difficult program, but very, at the end of the year, I couldn't say I was the most interested in engineering. But more than that, what scared me was that we went to a conference of engineering companies that were doing hiring and to do you know, internships at their sites, and very few companies attended the year that it was my turn to intern. And that really scared me even at the student level, because I figured if it was this competitive as a student, then I was going to be having to compete at that level for my career, in my career. So I really had to sit down a heart-to-heart with myself, what I wanted to do, and I felt that medicine was a safer career path, although I couldn't tell you at that point in time what I wanted to do. So I ultimately did change out of engineering. I went into medicine route, the pre-med route, and I got in. But even when I went to med school, I knew medicine was for me. I just didn't know what specialty. So I started off with ER, and then I went into ENT subspecialties, so the emergency room medicine and ear, nose, and throat specialties. And I wanted to learn a little bit more about the ear, nose, and throat. So I went on a mission trip to Mexico, and they were supposed to have a more in-depth exposure with U.S. doctors that were helping out several communities there. They really needed help with the eyes, and not as much help. Or I should say, there was so much help in the ear, nose, and throat section that we spared a little bit of that help onto the eye section, which is where I came in. And unfortunately for me, at the time, I didn't realize that this was going to be a great thing for me, but they did shunt me over to the eye section. And what they were doing there was getting together some of the blindest patients in that community and operating on them. And the first day that I saw the surgeries was really boring because all I was doing was seeing people operate. But it was the next day when it was time to remove the patch, that some patients that were there being operated on that had not seen their family for 20, 30 years and have never had met some of their family members visually. Having removed that patch and being there in that room and having people see themselves jump for joy and meet each other for the first time visually, I thought that was just a very incredible experience to be a part of. And we did that several times. I think that week we operated on 200 people. So it was a very emotional week for me and a very eye-opening week for me in the sense that I came back knowing what I wanted to do. Not only for at that moment, but for the rest of my life. And I'm still doing that now to this day. So that's how I got into the eye world, and I haven't looked back. And it's still every week that I operate, it's still a very good experience. And so this has led to my current passion, which is cataract surgery. It's what I do for a living. But if you talk to every doctor, there will be a story just like that moves you to do what you want to do. And I think you have to find that in medicine. And you may not always find it when you apply, but you will find it once you get there. But I can tell you that every physician shares the same stories, that they all want to help a group of people in a certain way. And they have a reason, whether it be their family members have gone through the same problems, or they have gone through those problems, or they had an experience like this trying to help someone else, and it was just overwhelming. Nonetheless, if you haven't had that moment now, it doesn't mean medicine's not for you. It just means you haven't been exposed to that type. And I wasn't exposed to it while I was in medical school. So I think it's made me a better person. So outside of the surgeries on a weekly basis, what does my day look like? Personally speaking, I have a clinic that's 8 to 5. I guess other good things about ophthalmology that it's. I'm not going to say we don't have emergencies, but they're not as common emergencies. So we do have very regular hours, 8 to 5. I do have to take call in the hospital about once every 2 or 3 months. And we interact with pretty much every specialty because the eye affects any part of the body, from the kidney disease to liver disease to heart disease and diabetes. Everything affects the eye. So we do have to work with every specialty that there is. So I like that communication. We work with other surgeons. We work with other medicine doctors to keep the patient the patient's eyes the healthiest possible. So what skills are necessary to kind of excel in my profession? And I think, honestly speaking, that if you take a person that has the determination and the will to do good, then you're going to do well in medicine. And it really, what it comes down to is grit. Grit meaning no matter what obstacles in front of you, you're going to get up. And if you've been through a hard time, been through financially, emotionally, that's life. Everybody's going to go through that. And you'll hear in the 4 years you're in med school, 4 years you're in training, you're going to hear many stories. I had funerals to attend to. I missed birthday parties. Many things happened during those 8 years, but you just have to get back on and focus on your goal. And if you do that, if you have grit, you can overcome not only this obstacle, but pretty much anything that life may throw your way. So I do want to share, it's one thing to say what we experience, but another thing to show what we experience. So I want to share a little bit about what the experience is usually like during patch removal day. That's really my favorite day of the week, is the next day after surgery. And this is an example of that. So before I start the video, I just want to read the line. So this is a patient that has not seen their family in several years, and he had cataract surgery, is now about to be shown what life is like now that he can see.
Okay, Daniel, now I'm almost ready to bring your hand down from your eyes and you'll be able to see.
Ready as I'll ever be.
It's okay, honey. Everything's gonna be okay.
You're doing great, Dad.
Now here we go. Oh my God.
I might finally be able to see. I might finally be able to see my wife and daughter.
Here we go. Now you want to be very careful because your eyes will be sensitive to the light. Good. Now you
Wow!
Can you see?
Yes!
Yay!
Come here, Alec! I want to see you close.
Say hi.
Hi, sweetie. You are more beautiful than I ever could have imagined.
Congratulations.
Thank you.
Thank you.
Thank you.
So that's just a reflection of some of the emotions that are going through, for the most part, in patch removal day for us. And so it's very, very addicting to be able to do that on a weekly basis and to have that very personal touch with these patients. And it's just something that you cannot pay for. It's a very addicting feeling to be part of, and so that's why we do it. But how do we get there? So this next video shows you very quick, maybe 2 minutes, regarding an actual procedure of cataract surgery. So how we actually get the patients to that point.
DHR Health Eye Institute.
Hello. I will briefly take you through one of my cataract surgeries. I hope you enjoy it. At this time, the eye has already been numbed, and the patient is comfortable. We enter the eye and start opening the capsule of the cataract. It's a very fine technique. The capsule is what supports the lens of the eye. The capsule will be used to support the artificial lens. The lens is separated from the capsular bag through the injection of fluid. The lens can now spin freely. I start breaking the cataract into smaller parts to allow for removal. Careful removal of all pieces begins. Breakup of the cataract is done using ultrasound energy. fine fibers can remain after the cataract is removed. These are gently removed as well, in a process called cortical cleanup. It's clean and clear now. And we're ready for the lens. Small manipulation is needed to center the lens and ensure appropriate positioning. That's it. We're done. Thank you for watching.
But a couple helpful tips from the beginning, especially for those of us going into or wanting to be pre-med. I think starting from the beginning, what you can do is being active in your community. So there's a difference between, shadowing, which is essential, I think, to know that you really want to know to do this. But having 500 hours of shadowing does not make you a better student, because you're not really helping anybody. You're helping maybe your interest, but you don't need 500 hours of shadowing to make sure that you want to do pre-med. I think those hours would probably be better used in helping other people, like visiting elderly homes or doing Habitat for Humanity, something that'll help somebody else, not just looking inside. And then that'll also look better on any application that you do to medical school. Just remember, study hard. It does take grit. It does take determination. And as long as you have that, you can overcome any smarts deficits. It's really, how can you dedicate yourself to this? Because any one topic in medicine is easy to understand. You just have to be determined and take the time to understand it. Set your long-term goals. Stick to the plan. Every long-term goal is going to have bumps in it, but you have to veer yourself back onto course. And as long as you're dedicated to the plan, you should be able to succeed. And something that was very helpful for me is finding role models. So people that are just ahead of you in the same process, and people that are way ahead of you in that same process. And seek to them for guidance as to what you need to do, what you can look forward to doing, and help those people, use those people to help you attain your goals. And thank you for listening.
Hi students, attention! We want to make sure that you know everything there is to know about stackable credentials and certifications. You know, if you're on the pathway to health science, you want to make sure that you're covering everything you need to do. So look at pathcentral.org for our CTE landing page. Thank you.
Hello, PATH students. My name is Marina Ibarra. I'm a licensed professional counselor, also known as an LPC. I got my bachelor's degree here at UTRGV. It took 4 years to complete my bachelor's. I then decided to get my master's degree in clinical psychology. I then tested to become a licensed professional counselor. While you're attempting to become a licensed professional counselor, you need to obtain a supervisor, and that usually takes about 2 years to complete, right? Right now I'm working here at DHR as a primary child therapist. I work with children from ages 4 to 12 and usually provide group therapy, individual therapy, and treatment planning. I always knew I wanted to become a therapist because I became interested in psychology early on while I was obtaining my associate's degree. I attended school, like I mentioned before, at UTRGV. I got my bachelor's there and also my master's there. I paid for school through financial aid, so fortunately for me, I was able to obtain a loan, and that's how I was able to finish my schooling. The hardest part about finishing my schooling was the time. So a lot of people finish after their 4 years, but in order to become an LPC, you need those 2 additional years and then 2 years of training. So while all my friends were able to start with their careers, I had to wait a little bit longer, and I think that was the hardest part while I was obtaining my career. A day in my life looks like working with nurses. I work in a multidisciplinary team with pharmacists, nurses, psychiatrists, and case managers. So basically what we do is we try to figure out the best treatment plan for the patient that we're seeing. For me, that would be children, and so it's always a lot of fun. Some of my favorite things to do at work is, provide group to the children. It's always fun whenever they say, they're having fun by learning about emotions and other coping skills and things like that. The skills that are necessary to become an LPC would be, to have patience, to be empathic, to be able to listen, and also de-escalate situations that are, very intense sometimes. If you have a child who's maybe becoming a little bit irritable or maybe even sad, you have to learn how to de-escalate without feeling stressed. So some fun facts about me is that, I like to play guitar, and sometimes I introduce the hobbies that I like into groups. So for example, I also like to draw and paint. So we do a lot of art therapy type of groups where I have the children paint or, listen to music and things like that. So some helpful tips if you're interested in becoming a licensed professional counselor would be to speak to an advisor to see what path is best for you. So there are different ways of becoming a licensed professional counselor. One way would be, obtaining your bachelor's degree, and it's usually within the social sciences, so it could be anything like psychology, rehab counseling, or even education. From there, you would have to get a master's degree, which is a 2-year degree, and it could be either in clinical psychology, rehab counseling, or education and counseling as well. From there, you need to make sure that you're eligible to sit for the national counseling exam, and if you pass that, then you'll be able to apply to become an LPC. And some advice that I give you guys is that, if you have a goal or any type of dream, to make sure that you never give up. If you ever need help with anything, you can always reach out to an advisor, a teacher, or even to me. I'll provide you guys with my office phone number or also the contact information to my supervisor if you're ever interested in interning with us. So, my office number is going to be 956-362-2720. You can also reach out to my supervisor, Jacqueline Mujica, and she'll go ahead and point you to the right direction if you ever want to pursue an internship with us. So again, guys, this profession is so dear to my heart, and hopefully you guys learned something in regards to how to get there. Like I mentioned before, I became really interested in counseling and psychology early on in college when I started taking that intro to psychology class. And the reason for that was because I saw a lot of my friends struggling with depression and anxiety. And so I felt that, I wanted to pursue a career where I could help others whenever they're feeling this way. So right now, because of COVID-19, I see a lot of patients maybe feel a little bit anxious because of the isolation and even just, fearful of, catching that virus. So something that I always tell them is, exercise those coping skills. Some of those things include, journaling, expressing your feelings through art, also listening to calming and soothing music. I know sometimes that can be very relaxing and we sometimes forget to do stuff like that. Also going for a walk with a friend, that exercise is really important, even if it's just for a little bit, at least 30 minutes a day or so. That could be something that, people could implement every day so that they're able to de-stress. So thank you guys again, and hopefully you can reach out to me if you're ever interested or have any questions.
Hello everybody, my name is Clarissa and I'm a nurse educator here at DHR Health. One of the topics that I wanted to talk about was effective communication. Now, you have to understand that most times as nurses, we can be the best thing that has happened to a patient in the worst day of their life. So it's so important that we are effectively communicating what the patient needs, as well making sure that they get the care that they need. We provide the patient with as much compassion and empathy, to provide them a good journey to their recovery. We have to just be more than just clinical knowledge. We also have to have interpersonal communication and skills. Communication is a vital element in nursing in all areas, in all activities, and its interventions such as prevention and treatment, rehabilitation, therapy, education, and, to promote their health. Understanding the immediate needs of a patient when they are sick is very important, because we need to make sure we address those needs as we see fit, in the sense that they came in for an emergency. We have to acknowledge what is the concern. Most times when people come to the hospital, this is the last place that they want to be. So being an active listener and listening to what the patient needs will help build that rapport. And rapport means that when you begin to trust someone, that you start to explain things in confidentiality. Active listening is a huge part of communication. You can't help people or assure that they understand what you are saying until you are listening. You see, if something falls behind me, I'm hearing something fall, but it isn't until I turn around that I look to see what the object is, that I'm listening objectively to what is actually happening. Also, part of communication is understanding the emotional state of the patient. We want to provide not just a physical well-being, but an emotional well-being for the patient. We have to be able to provide that deeper level of understanding. Also understanding the social determinants of health. For example, things that don't have to do with the patient's illness or trauma or concern at the time, but also what are other derivatives that are contributing to the patient's health. Maybe their financial status, maybe the fact that they don't have insurance. We're here to take care of our patient, and recovery is so important for us. We also have to be effective in communicating how to track the patient's care. Are they doing better? Are we being effective, right? We always want to assess our patient. We want to implement any treatments that we need to, and then we need to evaluate if what we did was actually benefiting the patient, and are they getting better? So what we are doing in response to that, is it working? We also want to make sure that we identify special needs, and that could be anything between a language barrier. If the patient is Spanish speaking, primary, which is here in the Valley, it's predominant. Everybody's primary language is usually Spanish, and then they understand English, but again, their primary language is Spanish. So we want to make sure that they know everything in their native tongue. They could also be someone that speaks Mandarin. We want to make sure that they're able to communicate their concerns in that aspect. So communication is very effective when they're able to relay their needs and their wants concerning their care. And that is important, because then they become an integrated part of the continuation of recovery in that aspect. We also want to make sure that communicating is also advocating for our patient. What do we see fit that is going to benefit the patient, that's going to provide a positive response? So in other aspects, communication, we also have to understand our body language, how we stand. When you are here and you're concerned about a patient, you want to have that open communication. So body language is another portion of communication that we have to relay. We have to also exercise patience, right? Sometimes we understand that you're going through a really bad situation and your emotions get the best of you. We know that you're not trying to take a sharp edge at us. It's just the situation is very emotional and very stressful, so we have to be very patient. focus on the feelings and the facts so that we are able to communicate and relay a better understanding of care. And you want to show proper respect. When you're showing respect on someone who is probably not at the best state and they're very angry, you know, you still want to say something like, what can I do for you? How can I help you? You know, please allow me the opportunity to make this right. What you can do now. You don't want to have a lingering conversation about what can't be changed. So you acknowledge what can be changed, what you can do better, and then move from there. Let's just move forward from this situation. Building rapport is one of the biggest things because the patient sometimes will feel intimidated when they're hearing bigger words that they probably don't understand, but they're too not embarrassed, but they just don't want to be asking for too many explanations. They just want the process to go a little bit faster. But when you build a rapport with the patient is able to communicate just why are they hesitating or what their concerns are. And that helps us communicate to the physicians on having an itemized care plan for that patient. We also want to recognize sensory challenges. We want to make sure that we provide the care and ensure the best comfort that we can for our patient. We also, in that sense, want to use plain language. Be simple and clear. What needs to happen? You know, when this happens, then this will happen. If this doesn't happen, then this won't happen. A lot of the communication, sometimes when people are faced with a difficult decision to make, often we try to help patient or patient family members avoid that feeling of guilt. You know, people don't want to be blamed for someone's end of life, choosing whether they should be disconnected or not disconnected. That's a very hard choice. And so as nurses, we have to be able to communicate what is the risk of doing something versus the risk of doing nothing and what is going to be at the most benefit. And always showing empathy is one of the biggest things that it can contribute to communication. You know, it's like when something is important to you, it may not be important to your parents. What's important to your parents may not be important to you. But because you love your parents, what's important to them should be important to you. And because it's important to you, it should then be important to your parents. So that is how I think of it. You know, you also want to think about how do they feel? Because we can be in a difficult situation where they say, you don't know how I feel, or you don't understand. You're absolutely right. I don't know how you feel, but I can see how it makes you feel. And that makes a whole lot of difference. So it's so important in communication that we're actually understanding. And one of the biggest things in understanding is to read back what you think you understood. Always building on what someone knows before you engage in further education has a more promising result. So make sure that when you're communicating with someone that you are actively listening to them. I live by Maya Angelou. People forget what you say and people will forget what you do, but people will never forget how you make them feel. And that is why you have the friends that you have, because they make you feel good. That is why you can't stand to talk to certain people who have made you sad, because they made you feel sad. And we always want to make sure that we have effective communication so that we can make our patients feel that empathy that we're trying to bring across. So I hope that this has helped you in your communication. And it's not just for nursing, it's in every field of aspect and anything that you do from here on out. So work on your communication, really understand what needs to happen, and being empathetic and valuing what people feel is always very important. Thank you. I hope you have a great day.
Firstly, I would like to thank everyone for tuning in. Just a reminder, this is a live segment where you will have the opportunity to ask questions. I will answer questions after I share with you a little bit about myself and my career here at DHR Health. Feel free to submit any questions you may have throughout my presentation. You can submit those by going to www.menti.com and using the access code 1647598. The URL is www.menti, and that's menti.com. So my name is Karim Buhala. I'm an RN. I'm originally from New Jersey, and I moved here when I was 16. My mother's a nurse, and there was a large shortage of nurses here in the Rio Grande Valley, and we ended up moving. I've been a nurse for 9 years, and I've been with DHR for 12 years. My first exposure to, so my specialty is in NICU. So NICU stands for Neonatal Intensive Care Unit, and I deal mostly with premature babies and babies who kind of need assistance and need some kind of support when they're born. My first exposure to this, I didn't know I wanted to be a nurse, really. I started out as a unit clerk there in the NICU. As a unit clerk, really, it was mostly just kind of answering phones, putting in orders, helping out with some of the parents and customer service. And through that exposure, I decided that I did want to become a nurse inside the NICU. It took me about 3 years with prerequisites and going to South Texas College here in the Valley. So the way they do it there is you just take your core subjects, and then you try to get accepted into the nursing program. I specifically went to STC. I know UT-RGV has one, and I think RGV College even has an LVN program. But once you're accepted into the program, it was about 3 semesters. While I was working at DHR, I did pay for my own school. But of course, there are always scholarships, grants, etc. available. But just a little bit of an insight, I guess, into what I do in NICU. So mostly in NICU, we do get premature babies who need some kind of support, whether it be oxygen, they need medications, they need IV fluids, etc. But for the most part, it's not unusual even for full-term newborn babies to be in our NICU, even if it's just temporarily. In comparison, I just want to kind of show maybe a difference in size between a regular baby and some of the babies that we deal with. This is kind of what we'd be calling maybe our full-term newborn baby. And in comparison, we get babies this small and like maybe this small and even smaller. Our smallest baby that we've ever had, I believe, was probably around the 500 gram mark. And maybe if you look at from like maybe your elbow to your wrist, that's how long this baby was. So very, very small baby. And I think that's probably the most exciting thing about what I do in the NICU. A normal day in the NICU usually revolves around receiving your patients, assessing your patients, and kind of taking everything from there. So at first, other nurses that I know that I went to school with, they're kind of, they can't imagine themselves taking care of little babies. But it's not as scary, really, as you think. But really, I think most of the training you'll get throughout the nursing program. And then after that, even when you get to the floor in NICU, it's a very small kind of portion of all of nursing, and they don't really teach you much about these premature babies or these babies that need help. So if NICU might be something you're interested in, maybe you want to get involved with babies, but you kind of are scared. Usually, once you get hired in the NICU, that's kind of where you learn most of your role. Things that you do need to be strong with are, especially when you deal with babies and families, okay? A lot of the families that you get are, you really wouldn't even know the NICU existed unless you knew somebody who had a premature baby or a baby who needed that kind of help, I guess, when they're born. But you really do need to be empathetic towards the families. You need to have a positive attitude, not just towards the families and the patients, but also to your coworkers. And you really, really need to have professionalism and critical thinking. So if you do go into nursing, you'll hear a lot about critical thinking. Critical thinking is really just being able to think on your feet. For the most part, I think, especially in NICU, things get bad very, very quickly. Or when a baby's going to be born premature, it's usually very, very sudden. So one day you could just be having like a nice, normal day, and then next thing you know, there's a very, very small baby who was just born and needs help right away. So the critical thinking aspect, you really, really just need to be able to stay calm, use everything you know, use all the tools you know, ask questions, ask for advice, ask for help, and just try to work as a team to help these patients the best that you can. Math, I'm sure you'll find out if you do go into, the healthcare field. Math is always important, especially when you're giving any kind of medications. So very basic kind of math, so-and-so weighs 1 pound and you're supposed to give 2 milligrams per pound. How many milligrams are you going to give? 2 milligrams. It's very once you know the dosages and once you get that training and education, it should come a lot easier. The other types of professions, I guess, that we work with a lot in the NICU, if NICU is something that interests you, we work a lot with physical therapists, occupational therapists, speech pathologists, neonatologists, nurse practitioners, and respiratory therapists, and even ultrasound, echo, and radiology techs. So physical therapists, of course, they're especially in the NICU. So if you guys got already kind of like an introduction to any of these positions, as far as relating to the NICU, the physical therapists do see a lot of the babies when they're born very, very premature and they're always laying down, or they're on some kind of ventilator and they're always laying on their back. The physical therapists go and sit with each baby one by one, get them out of the bed, start stretching them, rotating them, making sure they have like a nice range of motion. You'd be surprised, a lot of the times positioning is very, very important to the baby. They need to be kind of kept in a position which is natural if they were still inside their mothers. The occupational therapist, kind of the same thing. The speech pathologists, of course, they help in the NICU setting. They help more with strengthening the muscles in the mouth and the jaw and the tongue and helping these little babies who weren't ready to eat by a bottle yet be prepared to feed. The neonatologist, of course, that is a medical doctor who specializes in the neonatal field. Nurse practitioners, while the doctor's not there, if you really want to continue with your nursing education and even become a neonatal nurse practitioner, the nurse practitioners pretty much can do almost everything the doctor can do. They intubate the babies, they attend to high-risk deliveries, they order medications, and they see all the babies every single day and kind of make changes to help them, go home a lot quicker. The respiratory therapists help for any oxygen needs that the babies need. They attend to deliveries and make sure they're resuscitated if they need to be. And the ultrasound, echo, and radiology techs, of course, help us with some of the tests that a baby might need. Ultrasounds, a lot of the times they check the heart. The echo tech. The ultrasounds, we check a lot of the baby's heads. They have very, very sensitive heads, brains, kidneys, etc. So usually when we get some lab results that might be a little bit questionable, maybe they'll order some of those ultrasounds. The radiology techs, any baby having any kind of difficulty breathing when they're first born gets an x-ray. It's pretty cool. Instead of, I don't know if who's gotten an x-ray before, but instead of taking you to a room and taking an x-ray of you, they actually have a portable machine that they go and they just kind of take an x-ray of a chest x-ray of any babies that do have that difficulty breathing. I guess some interesting things about NICU, it's not just preemie babies and it's not just small babies that you might be scared to handle or deal with. A lot of the times big babies can be NICU babies too. There's a lot of diabetes in the Rio Grande Valley and even gestational diabetes. And babies who are from diabetic moms typically do have, I would say, like premature lungs. And a lot of the times they need at least a few days of some kind of oxygen therapy. So if you want to go to nursing school, or if you are interested in being in the NICU, some tips I have is to get some kind of introduction to the healthcare environment. Throughout my time at DHR, I've even seen students round with our neonatologists because they were interested in maybe being a doctor one day and specializing with the babies. I've seen them just come and work as students. I've seen them work as volunteers in the nursery, helping to feed babies. Of course, this is pre-COVID. Or you could be like me. I didn't really know I wanted to be a nurse, but when I first got that job as a unit clerk in the NICU, that's kind of what motivated me to continue going to school and working in the NICU. And I think that might be all, guys. Just ask around. Try not to take, too big a break if you do after school. Try to, take at least some core subjects. Always ask for advice or help. And I would say nursing is a great profession. If I ever decided right now, I do have NICU experience. I've been there for 9 years. I've been a charge nurse there for 4 years. And recently I switched to nursing education. So now I'm actually not taking care of the babies anymore, but I'm working as an educator to all the nurses. So there's always a lot of flexibility as far as what you want to do. You get tired of the babies, you want to go become a nurse practitioner, advance your career, make a little bit more money. You don't want to take care of patients anymore. You can always get to the education side of things like me. You can become a legal nurse. You can, work with the insurance companies to audit home health charts. So there's a lot of flexibility there as far as nursing. The cool thing is also, as far as working in some of the higher risk settings, like the intensive care units, a lot of the times they really, really encourage you even to be a new grad. So it's not like you have to graduate, work maybe in some kind of position you don't like, and then try to get your chance to go into NICU. A lot of the times we like hiring new grads, especially because they don't have any bad habits. We can train them the way we do them. And right now, as a nursing educator, one of the reasons why I took this job, I'm a unit-based educator, I'm assigned to the NICU, is because I really did feel like I wanted to help these new nurses become very, very strong nurses in the NICU. So maybe if you get hired in NICU, I'll be there to mentor you. And so now I think we are going to take the questions. Elizabeth, I think the screen shut off over here. Okay, so we're going to try to get through these questions kind of quick. So especially because there might be a lot of them. So I don't know how to go up. But someone asked me, has a job ever taken an emotional toll on you? Of course. There are times where a baby's wasn't ready to be born or has too many complications. And of course that becomes kind of like an ethical thing, as far as continuing to treat the baby, knowing that there's a lot of difficulties the baby will have now and in the future over, maybe sometimes asking the parents hey, we think it might be best to, kind of withdraw our care. And I think that's the most difficult part. Sometimes babies are 100% okay. They look beautiful. They're big babies. They're born 40 weeks, full term, everything's fine. And then suddenly we find out, they had something and, they don't make it. So I think a lot of the times, not just in nursing, but in life, death can be a very, very difficult thing to deal with. So that I think has been the most emotional toll that I've ever taken. Do we slap the baby's back so they can breathe? So that's actually not such a bad question because a lot of these babies, especially when they're born premature, there's that little mechanism. So hold your breath, and then when you feel that discomfort, you'll start to breathe again. You can't hold your breath for too long because your body just wants that oxygen, wants that air. So babies are kind of born with a premature respiratory control center in their brain. So a lot of the times these babies will just be peaceful, sleeping, and the next thing you know, they just stop breathing. In those instances, we don't slap them in the back, but we do sometimes rub their back, or we kind of like, almost like I wouldn't say tickle, but we kind of just like rub their back or just try to stimulate them in any way possible. Sometimes rubbing their feet with your thumb, just to kind of get them to like, kick in their breathing again. Do I miss taking care of the babies? I do. Actually, during this whole time, for a few weeks, we were required to work back on the floor. So it was just kind of very, 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 very comfortable to me getting back on the floor. I was even charge nurse one night. We had a baby that needed resuscitating. That's also the thing. There always needs to be a nurse that goes to these deliveries. And sometimes it's just a normal delivery. Baby gets stuck or something, or you find out, there's something else that they didn't catch before the baby was born, and the babies need help. So I think that's kind of like almost like a little thrill. So, like you like going to these things and being the one to help these babies survive. What was the longest I stayed in the hospital to take care of a premature baby? So we do switch shifts, guys. Like usual nursing shifts, I would say, in most patient care settings are 12 hours. I know sometimes in the operating rooms and things like that, because you just keep getting a patient, getting rid of a patient, getting a patient, getting rid of a patient. Sometimes they do like, 8-hour shifts over the 24 hours. But usually for patient care, you do 12 hours. If things get really busy, somebody's late, somebody called in, there's not enough people to take care of the babies, usually, you'll stay a little bit later. But for the most part, it's just a 12-hour shift. You take care of the baby while you're there. You do everything that's scheduled for that time period, and then you just go home. A lot of the times, especially with nursing, there's always job availability. There's always, not always, I should say, but there's a lot of opportunity all the time to get overtime. You want to get paid a little bit extra. You're really attached to the baby. You like the parents that you're taking care of, et cetera. You could just keep coming back, be that baby's nurse, and kind of follow up to make sure that the baby gets that continued care. It's always difficult. I think one of the difficulties of my job when I was taking care of the babies is coming in and like getting to know the baby. So once you have a new baby you never met before, was just born while you were off, you come in, you're taking care of the baby. It's kind of like, okay, what's this baby? What's the history? What's the mom like? What's the dad like? Like how does this baby behave? And not like, baby's good, bad baby, good baby's bad baby, but no, how does the baby behave as far as like, do they like us to lay down in a certain position? They breathe better, do they cry a lot if you try to, put them in a certain position? Do they like having the pacifier there? Does that calm them down? So, you do need to get to know the baby. I knew this is what I wanted to do also when I became the unit clerk. So I was here as a unit clerk for about 3 months. I was already like, oh, cool, NICU's pretty cool, like we all work as a team. I deal a lot with the parents. I would have to like walk them back and forth, walk them back to the room, show them where to go. Of course, when the baby's first born, let's say it's a C-section, so the baby, was delivered in the operating room. I'll take the dad to see the baby and then go take him back to his wife, kind of like calm them down, if they're scared or they're worried. And then after that, I became the EKG tech. So I started checking the baby's hearts. So I would go and we'd do an electrocardiogram on these babies, and I would do this test for the babies who, when the doctor would listen to the heart, maybe the heart sounded a little bit, like the heartbeat sounded a little funny. We usually call that a heart murmur. And I would do the electrocardiogram. So just from that, I kind of thought, especially some of the nurses there, I'm like, I already pretty much help out. I'm part of the team. Maybe I should become a nurse. Maybe I should work here. And I did. And I paid for my school by working and going to school at the same time. So yeah, from the experience. So if you feel like this might be something that you want to do, just ask. You can probably call me even, or call the NICU, or call DHR and say, hey, is it okay if like I come in one day, maybe I can like shadow somebody, or I can, see what the doctors do, if I can, maybe help out with the babies, anything I can volunteer, and hopefully, besides the fact that we're kind of with the restrictions now with COVID, hopefully they can maybe work something out, either where things kind of like relax a little bit, or you never know. Have I ever grown attached to a baby? Yes. I mean, the babies, of course, when they're so premature, they don't behave like regular babies. They hardly smile, But no, you grow attached to a baby. I don't know what it is about my voice, but sometimes, a baby's crying. I'm just like, I'm like, hey, why are you crying? And, they just kind of stop and they look at you, and you do build that attachment. But I think for the most part, you build attachments to their parents. So you just know some people are just such sweet parents. They're going to be a good mom and dad. Their baby's in this unfortunate situation. They're worried. It's their first baby, or it's their third baby, and it's the first baby ever to be born premature, and they're just scared and they need help. And I think that's really more or less what you grow attached to. Of course, you give every baby the same care. You don't just take care of the babies of the parents you like. Or if you don't like the parents, you don't treat you don't treat your baby or their baby the same. But for the most part, that's what it takes to be a nurse. The same consistent values that you're going to do your job. You're going to do the best. You're going to do your job to the best of your abilities, no matter who it is. I mean, if you're a nurse and you work in the emergency room, and that person that you don't like comes in with like a broken leg, you're not gonna. Oh no, I'm not going to help her. Or I'm not going to help him. So, I mean, you just have a duty to yourself and to the people you're taking care of to take care of them the best way possible. Do hospitals offer therapy? Yes, we do. Our unit specifically does have she's a psychologist. She sits there a lot with the mothers. So a lot of the times, especially if a baby is in that kind of instance where they're considering withdrawing care, or if the baby just doesn't make it, she helps out a lot. Her name's Andrea. She helps out a lot with these mothers. Even when the moms aren't in that situation, baby's okay, but there is a thing called postpartum depression, and she helps a lot with these moms, and you'd be surprised how, I guess, even though their baby's healthy or the baby's only going to be there for a couple days, like you'd be surprised how much they actually need that kind of support also, that therapy. So absolutely, we do offer the therapy. And a lot of times we're the ones who take care of that. There is something called bereavement care. I've done it maybe 2 times in the whole 9 years I've been a nurse. But typically, your baby's not going to make it, or the parents decide, this is kind of like, let's stop doing this, like torturing the baby. Like, let's just, kind of like let the baby rest. The baby fought hard enough. And then you do have this deep interaction with the parents and the family members as far as kind of saying goodbye to your baby. So we do let them hold their baby however long they want, etc., offer them the support, but there is a time where you do need to say, like, hey, this is like the last time you're going to see your baby, and then, we kind of have to send them on their way. So it's very, very difficult. What are my thoughts on medical marijuana? Maybe this isn't the right presentation to answer that, but I'm sure you can do all your research. It is prescribed in a lot of situations for certain patients, so it is a practice that some physicians use. Is it true that it's good to hear babies crying because at least they are past? Yes, I like when my babies cry, especially at deliveries. So the baby's born, baby comes out really, really floppy with no movement. I get concerned. As a charge nurse in the NICU, you do go to all these deliveries that there's any issue that they're for example, if a mom's on medication that might make the baby too sleepy or might make the baby stop breathing. And these are usually any kind of sedation medications. Moms a lot of the time have high blood pressure caused by the pregnancy. So a lot of times they get magnesium. Magnesium does transfer to the baby, and sometimes they could have a depressed breathing reflex. So a lot of times they come out and they're just not breathing. They're super floppy. You would think already they have no life in them. So in those cases, a NICU nurse would have to go, or a NICU charge nurse would have to go with a respiratory therapist usually to try to help this baby in the first few minutes of life, making sure that they're breathing okay and assessing if they need to go to the nursery or they need to come to the NICU. And of course, I've brought my fair share of babies, but yes, baby's crying, great. Baby's not crying, I'm scared. You're scared, but you do your job. And that's probably also the hardest part of my job. What's the youngest age? Guys, as long as you have your RN, there is no minimum age. So I had a nurse now, I think she's maybe like 23, 24 now. She's already on her way to become a nurse practitioner. So she did the speed route. She like got out of high school or got some credits during high school. She went straight to like RN school. She got her BSN. She was working with us already when she was 20, 21. And then now she's almost done with her nurse practitioner. She's like 22, 23. In comparison, I started working in the NICU when I was 22. I got my RN by the time I was 26, and then now I'm 34. So I'm already in my 9th year. But yeah, the faster you get done with school, the sooner you can work as an RN. Age is not an issue. How many years of college is needed? So the program that I went through is called the Associate's Degree of Nursing. The Associate's Degree is usually 3 or 4 semesters. So it's usually 4 semesters, but a lot of the times at STC they offer a summer semester where everything's kind of like you go to school a little bit more, like you go probably nearly every day, but it's a lot shorter. So I think I went from a fall, a spring, and summer. And in the summer you take like 2 different semesters, but they're all cramped together, and that was pretty much it. So, you know, you go to STC, you go to your counseling, you ask them, hey, I want to become a nurse, can I see the program? Like the list of classes I need to become a nurse, and they'll give you the prerequisites you need to take. Take those online even, now that you guys are so used to taking online classes. You know, take those online, all your prerequisites, sure. I pretty much took all my prerequisites online, besides I think microbiology. I think I took a college algebra during the summer. I probably took like a history during the summer, but for the most part, I was working at the same time, so I did most of my stuff online. Once you're there, it's really just that 3 or 4 semesters at STC. The RN program, very, very demanding. So the question was, how demanding was your RN program? Super demanding. They do try to prepare you to the best of their ability for being a professional. So if they say, hey, this is your uniform, you're going to be wearing that uniform every day. This is your dress code. This is how you're going to wear your hair. You're going to cover up your tattoos. You're going to take out your, you know, any piercings that might be a little bit inappropriate, et cetera. And you're not going to wear them to the hospital. You know, like that's what they hold you to. The worst part, but it's also a good thing, I would say, is the nursing programs. The nursing programs, I feel, have a high, like they put a lot of value in you passing your tests when you finish. So in order to make sure that you do that, they do kind of set the standards a little bit higher. There is no C's get degrees. If you have a grade in the 70s, you actually do not pass that class. They want to keep you kind of like in the 80s and higher, just to make sure that you're really, really grasping all the concepts, et cetera. And as far as the dress code and everything, guys, like it's just, you know, don't try to break their dress code, because they will find out. But no, for the most part, it was pretty demanding, but you really have to be committed. If this is really what you want to do, you'll have no problem being committed. Sleepless nights while learning to be a nurse. I believe so. And it's mostly probably my fault, because, you know, maybe I'm a little bit behind on something, or I decided to work and go to school at the same time, instead of just focusing on school. So yeah, I've had it, but I really think if you're lucky enough to be able to just go to school and not have to worry about working, great. Like, it should be no problem. You should have enough, like, adequate time to finish all your work. Was I nervous the first time I had to deal with babies? Yes, absolutely. But they're a lot more resilient than you think. Babies heal faster. They recover faster. They're very, very resilient. They don't, like, you know, you pick them up and his head's like really weak because there's no neck muscles. Their head doesn't, like, you know, like roll off or anything. They're very, very sturdy. You just have to hold them the right way. And usually they're so small that typically just one hand kind of like on the back of the neck and the head, supporting the head, and then your palm kind of covering their back, and then just maybe grabbing their legs and their lower back, and just like this, and you can just move your baby. So is this how I would really hold a baby? Yes. So a very, very small baby, I would hold like this. What kind of food did I rely on during college? To be honest, since I was working and going to school, I would rely on everybody's leftovers in the unit. So a lot of the times, especially these nurses, their big thing is like ordering lunch. So whatever they had there that they ordered too much, they'd be like, hey, Karim, you want some? I'd be like, yeah, sure. How do you calm down a baby when they're crying? So we use a lot of times a pacifier, or the most common way is kind of like touch. So babies, a lot of the times, they don't want to be alone. Remember, when they're inside their moms at this age, they're curled up. They're all like in a ball, and they're just like really, really compact in a warm area, floating around in mommy's tummy. And then now they're born and they're like this. So a lot of the times, you know, you just kind of like hold them. You kind of like give them like a hug kind of with your hands. And if you just like do this, like if you kind of just like hold their hands by their face and you kind of just like scrunch them up and just like put your hands on top of them, they usually stop crying. What was the hardest class I took in college? Microbiology, by far. It was kind of hard for me to grasp. A lot of bacteria names, a lot of things like that. But, you know, it depends on who your instructor is. You'll tell me, right, Elizabeth? Okay. So I think we're coming kind of too close, so I'll try to answer as many questions as possible. Do you recommend this if you have a fear of hurting them, or do you think it can be overcome? Okay, if your only fear is hurting the babies, absolutely. I feel like you can overcome that. Once you start taking care of them and actually seeing like how... And of course, guys, like the smallest of the babies are more reserved for the nurses with the most experience. So it's not like you're going to be a brand new nurse and they're going to be like, hey, that's the toughest baby, go take care of that baby. You will work your way up to that once you kind of know, once you kind of gain the experience and gain the trust even of the doctors there, you know, in your NICU. But for the most part, yeah, if you just feel like, you know what, I might hold him wrong, I'm going to hurt him, like that absolutely, once you get a little bit of practice, that will 100% go away. If you don't feel like you're the right person for NICU, but let's say, for example, they pay you the most or something, I would not recommend you going to NICU. There has to be really like your heart into it. If you're not compassionate, if you're don't have that empathy and really, really go the extra mile. For example, me, it doesn't matter how busy I am, even if I'm 30 minutes behind, an hour behind, you know, there was a surprise delivery and I was taking care of that baby, not as the charge nurse, but just as the floor nurse. And I'm super, super far behind. But the parents of my other baby are calling, and that baby's totally fine. There's nothing going on with that baby. Really, I stop everything I'm doing, and I don't say, like, you know what, tell her I'll call her back, or tell her her baby's fine. Like, I will take the time and stop everything I'm doing, go talk to that mom, because you know what? The most important person to the parents is their own baby. So, I mean, some parents are at home, they're worried, they have other kids to take care of, et cetera, et cetera. You don't make the time for them, or you feel like, you know what, you're more important than the babies, and what you want is more important than who you're taking care of, that's when I kind of feel like you're doing it for the wrong reasons. So yeah, nurses get paid very, very well. Yes, you can keep going to school and make more and more money. Yes, you can work overtime and make more and more money. You can travel the whole country, and they'll pay you extra to travel the whole country, you know, and live in different cities and try different foods and whatever, but you'll obviously be traveling as a nurse. So nursing has a lot of great things, guys, but you really, really have to have at least that empathy within you. Have I ever felt guilt? No. There's a lot of times you can't do anything. I would understand if you make a mistake. You might feel some kind of guilt, but guys, that's why they train you so hard, and that's why like you practice so hard. Like there's always that little thing inside you where, I mean, once you get into nursing, there's very, very small, tedious things. Like they'll be like, hey, before you give that medication, make sure you check their ID bracelet. You ask them their name, you ask them for their date of birth, whatever. With the babies, we scan them, and then we scan their labels inside their little crib or isolette or whatever they're in. We have to be there at the bedside. We have to ask another nurse to come and check with us and sign us off on the computer. And the reason for all of that, guys, is to avoid making mistakes. So if you really follow the rules and you do all these little tedious things and don't cut corners, you'll never make a mistake. So you will never have that guilt. Has anyone ever dropped a baby in the room? Not a nurse. And that's just here at this hospital. I'm sure it's happened before somewhere. But which ones are easy to take care of, males or females? So don't be mad, but females. Females are stronger. They don't cry as much. They, are born very, very early, and they rarely have any issues, like, as far as males. So males, a lot, the little boys, they really, really do, I think, usually have like a more difficult time statistically. But, I don't know why. But go girl babies. How do you do compressions on a premature baby? With your thumbs. So there is in regular CPR, of course, guys, you do your compressions like this. On babies, you'll actually, with the baby laying down, you'll just grab them under their arms and you will just push. So as a nursing educator, I actually got my NRP instructor's license, and NRP stands for Neonatal Resuscitation Program, and I actually teach this too. So even if you ever want to sign up, you could kind of buy the program and, but yeah, you do it like this. And I think they even kind of show you this in BLS for the bigger babies, so it's pretty much the same. What was the largest weight baby we've had? Maybe like 11 or 12 pounds. And they're just like really, really huge. So the more, I would say these babies are typically babies from diabetic mothers. But just that increase, I think, of sugar in the baby's blood just kind of helps them have what they call, I guess, like Texas preemies. So sometimes, you'll have a full-term baby that's just huge, huge. And sometimes you'll have a preemie baby that just looks like a normal baby. And those are called, at least in our unit, we usually call them like Texas preemies. And they're just, they're just bigger because of, I guess, like all the sugar they've been getting. And I think, does that sound like it? That's all? Okay, guys. Well, thank you for tuning in. Again, if you have any questions, try to reach out. Maybe find a phone number where you can contact somebody should be able to help you. I don't even mind you guys contacting me. If you want to ask for me, maybe I can help at least redirect you into the right person to help you maybe, explore NICU or explore nursing or explore any of those other jobs. Just let us know, and we're here to help.
Hi, PATH students. My name is Ileana Elizondo. I am the Director for Interpreting Services at DHR Health. I've been in the interpreting field since 2011. I do have a history in education, but we'll talk about it as we go. Maybe I should start how my education started with. My first language is Spanish. I came to the United States and my English was very, very limited. I started my schooling at Texas A&M College Station. So that was a big, big struggle for me due to that. First language was Spanish. My English was very limited. First semester I failed. Second semester I was in probation. I kept asking my parents, like, let me just go back home. And that wasn't a choice for me. So I did biomedical science. From there, I jumped to nursing, did all my nursing, became a nurse, and my father came with cancer. So I dedicated to his last 2 years of life for him. I was at home, I was his nurse 24/7. After his passing, I come back and I realized I couldn't do nursing anymore. So that's when I went back to school, and that's when I fell in love with American Sign Language. I did the course as in American Sign Language as an interpreter at STC here locally in McAllen. It was fun, totally different. It's an associate's that they have. I just did the course as I already had a bachelor's. It was fun interacting with the deaf community. So it's like any other language. I always say sign language is a lot like math. If you stop using it, you forget it. And the more you work with it or you're around it, you understand it best. So in 2011, I finished the program, and that's when I started involving myself in the deaf community. Then this position opened at the hospital. I never thought I would be back at the hospital, but it was just perfect because almost all my careers, all my education came combined in one, which was I had the nursing as a background and then the interpreting as in sign language. And I am a trilingual, so it's English, Spanish, and American Sign Language. And Texas has 4 trilingual interpreters. I am considered one of them. It was interesting on how everything just came together. I never planned to be where I am at now. I guess all the path that I went, life gets in the way too. So I think everything comes together. My first 2 careers, which was my biomedical science and nursing, my parents paid for that. And then when I came to interpreting, I paid for that. And I continued school. I didn't stop there. I did another bachelor's on healthcare administration. Last year, I finished my master's in business administration, and this May, I'll be done with my second master's in science and finance. So I guess I like school. Okay, in my position, I don't have a normal day. As today, it's been a crazy, crazy day. You can tell my hair, my face, everything. I've been in the hospital since 3 in the morning. I got called for an emergency accident, and this patient was deaf. So I had to rush myself to the hospital to be the patient's voice, and I could sign for him what the doctors were telling him. Luckily, the patient's good, he's stable. So at this point, I called another interpreter to come and relieve me so they could, so I could continue with my normal day as is. But I am scheduled Monday through Friday, 8 to 5. In that day, it's never normal. Like I said, I can be out interpreting, I have meetings, I have appointments. So it's very, very, it's always a challenge, it's always a different day, which I love. I don't like routine, so this is the perfect position for me. But you also, a lot of people don't like that. So if you have a job very demanding as this one, you have to adapt to the times, to your phone. It's always with me in my hand, answering and all that stuff. The skills I think that you need for something like this, you have to be very humble. It is a very, very humble position. It is a humble work that you do. I think the way I connect with it is because my first language was Spanish. And being in College Station in a classroom with over 200 students and everybody was speaking English and the professor was going 100 miles an hour, I was lost, completely lost. Students would talk to me and I would be like, no, and I would just walk away. So that's how I connect, how I can know the feeling of a deaf person, that everybody's talking and they're like, okay, what's going on? They're taking off my clothes, they're injecting me, they're giving me this, and they don't know what's going on. So that's very, very scary. I always give the example, let's say you're out in Japan, having the time of your life, and for whatever reason you end up in a hospital and nobody speaks your language. How are you gonna feel? So you have to be very, very humble about it. Also, if you're bilingual, embrace that. Don't lose your other language. Make sure you continue with both languages because you just never know. We do live in an area where almost everybody's bilingual, but once you go up north, trust me, you're valuable and you are considered like 2 people in one. So, a fun fact. I guess a fun fact in my career is especially signing, and if I'm around other people that know signing, I can be on the other end of the room and we can be chit-chatting. And it's incredible because as soon as one person realizes, we have everyone's eyes on us like, okay, what are you saying? And so we're laughing and doing all this stuff and people's like, okay, we want to know what you're talking. I was like, no, you can't unless you know sign language. And that's about it. embrace your soft skills, empathize with other people. Always, it's good to always help. If you can help, just help out. I always think of, I see it in stores where people don't know the language and they're struggling and they just want to do a simple payment. I always go up and help. So please, that'll be good. Helping others, it's awesome because you never know when you're gonna need that help. And it has happened where I'm out and they're like, oh my gosh, you were here, you helped my mom interpret for her and this and that. And I honestly wouldn't remember. I see a lot of people, but it feels good. It feels good. And I mean, I'm here in the hospital. If you ever need anything or you want to reach out to see if you want to take this path and as a career, feel free. My work phone, it's 956-362-7258, or my email, it's i.elizondo@dhr-rgv.com. Thank you guys, be safe.
Good morning, students. It is a pleasure to be here with you today to speak to the pathways aligned to healthcare students. My name is Dr. Lisa Trevino. I'm the Vice President for Research and Development at the DHR Health Institute for Research and Development. So I'm here to talk to you a little bit about my path to becoming a molecular biologist. That's what I went to school for. So a molecular biologist is a scientist in any other term that looks really deep into the molecular biology of our health system. I went to PSJ, as I mentioned, and after PSJ, I attended the University of Texas in San Antonio, UTSA, and I received a bachelor's in biology. And it was at that time that I was still undecided if I wanted to go into medicine or if I wanted to go into science as a career. And I know that clinical research and biomedical sciences as a career is not as emphasized or mainstream as you would to become a physician or a nurse or a pharmacist, which are all amazing professions. I just wanted to take the route of becoming a scientist so that I could help the physicians and the nurses and the pharmacists better treat our patients that have some, rare diseases like we see here in the Rio Grande Valley. So let's just say I went to high school, I got a bachelor's, I followed on to receive a master's, and I got a little bit deeper into the science, and I did endocrinology, where I looked at our hormones and our metabolic system that we have internally. And I think it was when I received my master's in biotechnology or endocrinology that I decided that I really wanted to focus on science. So as you can see, I continued on with my education and sought higher education. I ultimately received a PhD in molecular biology. I moved to California and received a doctorate. And so if you look at the entire time that it took me from high school to a bachelor's, to a master's, to ultimately receiving the doctorate, it was quite some time. Let's just say, let's do the math. So 12, right, to get through grade school and high school, another 4 to get my bachelor's, another 2 to get my master's, and then another 6 to receive my PhD. So that's several years, many years, to receive ultimately my doctorate. But it was something that I was really passionate about, and that's something that I'd like to emphasize to students here. Find something that you're passionate about and follow it. Like I mentioned, PSJA is my alma mater, UTSA, and then of course I went to the University of California at Santa Cruz and received my doctorate. I enjoyed this profession because I was able to interact with many professions. Like I mentioned, physicians, nurses, pharmacists, engineers, because all of those, let's say, professions and expertise is critical for us scientists to make discoveries, to be able to advance medicine, to advance the latest technology to be able to bring to the patient community. So if someone were to ask me what are the skills necessary to succeed in this profession, I would just say one of the biggest skills is determination and resilience, because trust me, it's not easy. Nothing in life is easy. There's many struggles along the career path, whether it be in education, whether it be personal. So I think if I had to tell you the most important skill, I wouldn't be able to give you one, but I would say certainly to be determined and to be passionate and to understand that what you're doing, you really have to find the love and drive to do it, because then it won't be difficult for you to continue. So I'll talk to you a little bit about some fun facts about my profession. So the beauty of research and really biomedical science is that you're allowed to be as creative and to be as innovative as possible. You get to ask all the cool questions. Why does this happen? Why does a cell divide? How does cancer start? How can we stop the cancer? So the most fun part of my career, or my training, I should say, as a scientist, was the fact that I was able to be creative and innovative, and I could, ask as many amazing questions and do the research and scientific process to help answer those questions. Let's see, so helpful tips maybe that someone may be interested in moving forward with a career in biomedical science is speak to your professors, speak to your teachers, and whether it be right now that you're in high school, speak to your counselors, let them know that you're interested in going in this direction. And I have to emphasize, because it really wasn't emphasized to me when I was in high school, that biomedical science allows you to be at the forefront and cutting edge of delivering amazing medications, vaccines. We're all right now in this pandemic trying to find a vaccine or a cure or an effective treatment for COVID. So it's really important to stress and to identify that you want to move forward in not just treating and being the practitioner for treating patients, but also on the discovery and the scientific side. So speak to your teachers, professors. You're always welcome to reach out to me. Certainly you can call me at our office or at the DHR Health Institute for Research and Development. Our number is 362 2390. So 956-362-2390. Reach out to us, ask us questions. You could feel free to come and tour our research institute. And I hope this was giving you a little bit of light as to a day in the life of a clinical research scientist. Thank you. Stay safe, wear your masks, and wash your hands. Thank you.
Attention teachers and counselors, stay tuned for information about Pathfinders Academy 2021. This event is very beneficial to you so that you can learn all about the pathways and the different careers in the health science field through UTRGV and STC. So stay tuned and get more details. It'll be coming up this summer, so it's especially for all of you to share with our students.
Hi, PATH students. Up next, we have an interview with Dr. Jeffrey Skoobish. Dr. Skoobish is currently serving as the Interim Trauma Medical Director at DHR Health. He is board certified by the American Board of Surgeons in both surgical critical care and general surgery, and is the first surgeon in the Rio Grande Valley to have completed an acute care surgery fellowship. He earned his Doctor of Osteopathic Medicine and Master of Science in Musculoskeletal Medicine at the New York College of Osteopathic Medicine at the New York Institute of Technology, located in Old Westbury, New York. His general surgery residency was completed at the University of Arizona College of Medicine in Phoenix, Arizona. He then attended Harvard University, the Brigham and Women's Hospital, to pursue a fellowship in acute care surgery/critical care. Dr. Skoobish has been a recipient of many awards and is an active member of the Pan American Trauma Society and the Eastern Association for the Surgery of Trauma. He is widely published in peer-reviewed medical journals. He specializes in trauma surgery, emergency general surgery, and surgical critical care. He currently spearheads the trauma department and partners with surrounding hospitals and first responders to improve the care of trauma patients in the Rio Grande Valley. Dr. Skoobish is involved with conducting research in trauma and strives to bring innovative treatments to improve care for traumatically injured patients. He has practiced surgery in various South American countries in conjunction with the Pan American Trauma Society and is currently faculty for UTRGV, where he trains and mentors future surgeons. Please enjoy the following interview featuring Dr. Skoobish.
Hi, welcome everyone. My name is Dr. Elisa Alvarado with the Region 1 Education Service Center. And today in our interview corner, we have Dr. Jeffrey Skoobish, who is a trauma surgeon at DHR Health. A little bit about the PATHS project for those of you that are not familiar. PATHS stands for Pathways Aligned to Health Science, and it's a TEA Federal Perkins grant through Region 1. Currently, we serve 10 districts, and today we have La Jolla, Vanguard, and South Texas ISD joining us. I'd like to welcome Dr. Skoobish, and also I want to get some insight from you regarding how you got to where you were, and also insight for the students on how they get to pick their pathway. So to get started, my first question is, where are you originally from?
So thanks for having me today on the PATHS project, Dr. Alvarado. I'm originally from a small town in North Jersey called Haledon, New Jersey. It's a 1 square mile borough on the north side of the city of Paterson, New Jersey, which is about 10 miles outside Manhattan. It's basically the New York City area. And I grew up there, went to school there, and eventually went to college in Newark, which is another large city in New Jersey. How I went about going there, when I was really young, about 5 years old or so, I wanted to be a surgeon. And then as the years went on, I kind of forgot about it. I kind of drifted away from it. I don't know if it was laziness or just lost my way. And then in high school, I actually didn't even want to go to college. But the guidance counselors, I actually switched schools my senior year. It's a long story, and I switched from into a school where the guidance counselors, I remember them, they took me to the other school I was in didn't have guidance counselors. And so my first week at the new school, it was a better school, they took me to their office and said, so what'd you get on your SATs? And I was like, essay what? And they're like, you're a senior, you haven't taken your SATs? So they forced me to do it. I'm like, okay, I'll do it. So I took that. And they said, after this, you're going to sit in our office every week until you fill out these college applications. I was like, all right. So I filled them out. And I wound up going to New Jersey Institute of Technology, which is an engineering and science school in Newark, New Jersey. And after that, I actually didn't go right to medical school. I actually worked as a year for an engineer while I took my entrance exam, which is called the MCAT. And at the same time I was taking that, I was applying to medical school, and I was studying at night for the MCAT.
So your undergraduate degree is in engineering?
Computer science.
Oh, computer science.
Which is not a common thing.
So when you were going to school for computer science, did you know while you were taking the computer science courses that you wanted to do something in health science or you wanted to be a doctor?
So about halfway through college, at the same time I was already working at that small engineering company part-time. And I would look around me at work and realize that these guys would be older guys towards the end of their middle or end of their careers. And they were still sitting in the exact same cubicle for the last 25 years. And I had a very hard time sitting still. And so I really started to look around me and go, do I want that to be me in 30 years? And so I realized I don't want to do this. I don't want to just sit at a desk all day. So I started thinking about what else can I do? When I was younger, I wanted to be a surgeon. Is it possible? Can I go to medical school? And I didn't think it was possible because I didn't have any money. And I didn't know that there was ways to get the government to help you pay for it and all those things. So same thing with college. Because I was coming from a single parent home and we didn't have any money, I was actually able to get a number of grants. I think Perkins grants, I think a federal Pell Grant. And I was able to get almost my entire college paid for. I think I paid just a couple $1,000s for all 5 years I went. But it was about halfway through college, I realized, you know what, I'm gonna try to see if I can go to medical school. So while I was still finishing my computer science degree, I started taking the pre-med classes at the same time at Rutgers University, which was across the street from NJIT.
Oh.
I could walk over. We were allowed to take classes there for free if you were enrolled in either school. They're kind of joint schools. So I started taking them at the same time. It took me an extra year to finish, but at the end of 5 years, I finished all the pre-med requirements and the computer science degree.
Oh, wow. And you're a pretty young trauma surgeon because when I was talking to Elizabeth that works in the education department, she said, oh, you're going to be interviewing a trauma surgeon. And I thought, I'm going to be interviewing someone a lot older. How old are you?
So I'm 38 years old. I was born in 1982.
38.
38, yeah. So the pathway was, because you're probably like, well, how long does it take then?
Right.
Well, I only finished all my training about 2.5 years ago at age 36. So once I made that decision that I was going to go for medical school, I finished college and worked for a year while I applied. And then once I got in, actually, my applications kind of got screwed up. Remember, my school was an engineering school. Really, not a lot of people go on to medical school from there. And the doctor that was in charge of, he was a chemist, was in charge of keeping all the applications, actually disappeared suddenly for a few months, and I couldn't get him to send in my letters of recommendation. And then later I found out it's because he was having glaucoma surgery.
Oh, wow.
Anyway, so obviously they weren't really set up for it. So when he finally got the letters in, I only got one medical school interview. But I went on that one interview and I was like, well, I only need one. And I got in. So I took it. And then I was able to get mostly federal loans. I guess it's all federal loans to pay for all of medical school.
And where did you go?
Cheap. I went to New York College of Osteopathic Medicine in Long Island, New York. And I went there for 5 years. Again, I'd spent an extra year. The reason the extra year there was I got into like a TA program where I was able to help tutor the younger medical students, and they helped pay for the last 2 years of medical school.
Oh, wow.
And so that helped a little bit, and I also got a little bit extra experience in doing research and teaching. And while I was there, one of my friends told me I should go try working in South America, in Ecuador. So I started looking into the hospital he recommended, which was a big metropolitan hospital in Quito. And I discovered this guy named Edgar Rodas, who was quite an amazing man, who was a surgeon from Cuenca, Ecuador, came to the United States, did all his training here, worked here for a few years, and then realized he wanted to go back to Ecuador to help his country. And he built an operating room on the back of a truck and was driving into the most remote Indian villages in rural Ecuador in the Andes. And I didn't think it was real, so I wanted to go check it out for myself. So while I was a medical student, I flew down there, and I spent, I think, 5 weeks with him the first time, just traveling around the Andes Mountains operating.
And did you, were you already bilingual, or where did you learn Spanish?
Yeah, I grew up with Puerto Rican friends in New Jersey, and so I could kind of already speak Spanish.
Oh, wow.
Not medical Spanish, mind you. So there's no better way to learn the technical words than to work in it, because I can still remember the first time we were operating on the truck, they're asking me for the tools in Spanish. I don't know any of those technical terms, because who uses, the word for scalpel talking with your friends in the street?
Yeah.
So I learned all those on the fly, but you never forget, right? It's under high pressure. So, and working in the hospitals down there too while I was down there. And so in that environment, you learn how to speak the proper technical words very rapidly.
Wow. And so after that, how did you, I guess, end up or decide that you were going to be coming to work in the Rio Grande Valley? I mean, how did you hear about this area, or what brought you here?
Yeah. No, that's a good story. That's a good question, because it's a remote place down here too. And so that was my first experience. I didn't have any interest in that kind of thing, operating in rural. I knew I wanted to be a surgeon, but I didn't know what kind, and I didn't know doing what. And but after I worked with him, I said, "Wow, this is amazing. You can go to remote areas and really help people." And so after I finished medical school, then I went to do residency at the University of Arizona in Phoenix. And part of the reason I wanted to go there so badly was they had a lot of different rotations, including sending you 3 different times to go work at the Alaska Native Medical Center in Alaska. And so you got to go work with native populations in Alaska and do operations up there. And you would go there for 2 months at a time and work. So I got a lot of good experiences there working in remote areas. And also Arizona, there's a lot of transfers in from Indian reservations all around the state of Arizona. And that's when that's when I started to think about, well, if you're out there operating, great, you can help one person at a time. But if you can change a whole system, such as creating a trauma system, you can help hundreds of thousands of people and change so many lives. So that's when I started thinking about doing trauma. And also my residency was very trauma heavy. And so I started thinking about trauma, which is basically taking care of people that are involved in an accident, gunshot, stabbing, falling down. Any kind of traumatic injury is what we deal with then.
Wow. And so you saw the opportunity on here online, or you heard about the Valley through somebody that you knew, or?
So then I went to Boston to do my fellowship for 2 years in critical care and trauma surgery. And while I was there, we started looking at job offers, and this one sounded interesting. I was actually recruited by the UTRGV in 2018 to come down here. And it just sounded like an interesting place, and when I came down here, they kind of pitched it to me as it's a part of the United States that doesn't have a level 1 trauma center yet, even though there's so many people here. And we're trying to recruit academic trauma surgeons to help build that.
And what does level 1 mean?
So, there's hospitals and there's trauma centers. A trauma center is a hospital that can take care of really badly injured patients. And then there's different levels. A level 1 trauma center means you are the type of hospital or trauma center that the worst injured patients that come to you, you take care of them from admission all the way to getting them home. And you don't have to rely on any other hospital or sending them out. And the tradition here in the Valley for a long time was, we can deal with minor injuries, but anything major we ship to San Antonio. And what we're acting as now and hoping to get certified this year is an actual level 1 trauma center, which means we don't send out anybody. We already don't send anybody out, except for burns. But to get verified as that means you are the leader of the region as far as taking care of trauma patients. Just like they have in San Antonio, there's 2, or in Houston, or Dallas, or any other big city, the Valley deserves the same level of care. It's basically definitive care for any possible injury you can get.
Wow. So currently, right now, if somebody were to have an accident, there's no hospital in this region that could take care of that at a level 1 trauma center?
No, DHR is functioning as a level 1 trauma center.
I see.
We're awaiting our certification. We're currently a level 2, but we are going to be doing our level 1 site visit this year.
Oh, wow.
And no, we would take care of whatever injury the patient had. We would take care of everything. We wouldn't transfer them out. Again, except burns and certain pediatric injuries, because it's really hard to get full coverage for all of pediatric, meaning adolescent or children subspecialists. But for adults, we take care of everything.
And so, I know in my experience, and I don't have a lot of healthcare experience, and I certainly don't have a lot of trauma experience, but, you know, they talk about this fight or flight reaction, and a lot of people that see trauma, obviously, you know, they get really scared, some of them faint, they hyperventilate. How do you do it with trauma patients? I mean, what goes on in your head that you're able to kind of not be absolutely frightened of the situation?
So I guess a couple things there. One was I had really good mentors as examples. When I was a resident training how to do this stuff, I always admired the surgeons who were cool as a cucumber no matter what was going on. Guy comes in with a knife sticking out of his chest. They're just over in the corner. All right, you do that, and they're completely relaxed. And so I said, I want to try to model myself after those guys, rather than the frantic ones. That doesn't help anybody. And two, if you want to be a surgeon, you can't mind blood. You know, a lot of people see the sight of blood, they faint. That kind of stuff it wasn't having to get accustomed to it. Never bothered me. When I was a teenager, I worked at McDonald's. That was my first job, and I always had to go and clean the slides and stuff if kids dirtied them, urination or other things. And I never thought anything of it. And the same thing with blood. And after a while, it's just like a mechanic. You know, if a mechanic's in there working on an engine, you know he's going to get grease and oil all over him and under his fingernails. And he doesn't think anything of it. And it's exactly the same with a surgeon. If we're working on a body, we're kind of like a body mechanic. And there's blood all over the place. But to us, it's just like oil. You know, we're just working. We don't really notice it.
Wow. So what is your exact role at DHR Health? Like, do you just do surgeries? Do you work with a team? Do you work with other surgeons? What's a day in the life of?
Sure. So here, it depends what practice setting you're in. Here at DHR, it's more like a university setting. We have a team of residents and medical students that work on the trauma service. And so on any day, I direct a team of about 5 or 6 trainees that work under me. And as a trauma surgeon, we cover them from when you arrive at the ER, taking you to the operating room if you need to, or admitting you to the hospital to take care of you, or taking care of you in the ICU, all the way until hospital discharge, whether you go home or to a rehab. And we do that by having that team that I can direct all at once. And if you need an operation, we're going to take you to the operating room and we'll fix whatever it is, and then we'll take care of you in the ICU afterwards. So the trauma surgeon is kind of an all-encompassing jack of all trades, where I work between the ER to the operating theater to the ICU, and I can function in all those places. Most trauma surgeons are also board certified in critical care or in intensive care medicine, so we have privileges to work within the ICU as well as the operating room. So we can kind of work anywhere.
Wow. And do you see yourself being a trauma surgeon for the rest of your career, or have you thought of other areas that you may be interested in later on in your career?
Well, I can't really do anything else at this point. All in all, it was about, so I graduated high school in 2000, and then I did five years of college, then I worked for a year, then 5 years of medical school, 5 years of residency for surgery, and then a year of critical care fellowship, and then a year of acute care trauma surgery fellowship. So by the time I finished, it was the year 2000 until 2016 that I was done with all the training, and I was able to actually look for a job. And so after all that, you don't really know how to do anything else except that one thing that you're really good at. The other thing, other than improving the entire system of trauma here for the Valley, that I'm interested in is going back to the trucks again, because that's where I started. And I know DHR has a truck, as well as UTRGV has a mobile truck. None of them have operative capability at the moment. Some of them can do dental procedures, but eventually I would like to start using that to try to bring some operative care to the colonias. It's kind of what we were doing in South America. And if they can do it all the way down there, sometimes we would be 11 hours away from a city.
Wow.
We were able to operate on people. So why can't we do something similar here for the indigent population?
That's great. I want to ask for all of the students that are joining us today, what kind of advice do you have? Maybe tips or certain skills or anything that you would want them to know if they're interested in a career in health science, particularly if they're interested in a career in becoming trauma surgeons or working in trauma?
So, for all of the high school students out there listening, basically you can do whatever you want, okay? It's all up to you. You don't have to be the smartest person. You don't have to have amazing dexterity with your hands. People have this vision of surgeons that were extremely highly intelligent, and we have these hands that never move at all. I could basically train anybody to do surgery procedures. Anybody of average intelligence, I can train you to be a surgeon. It's more, do you have the dedication to train for 15 to 20 years after high school, unrelentingly, and not give up? If you can do that, little by little, we can teach you to be a surgeon. So, and we, as humans, actually, when they look at this, our DNA are actually very similar. We have very little differences between us. We're much more alike than we are indifferent. And so we're not just born to be surgeons. Surgeons are trained, and I can train almost anybody to do surgery. But it just takes countless thousands of hours of repetition and dedication to reading and studying and practicing tying thousands upon thousands of knots. And if you're willing to do that, we can train you. If it's a financial concern, you can get help from the government. I've never been given any money from my family at all to go to school. And I was able to go through all those years of schooling, all on grants and loans. Now, am I still paying them back? Yes. Am I going to be paying that back for many years? Yes. But it's possible. So you should know that whatever it is that your dream or desire is to do, you can do it if you stay dedicated to it, you don't give up, and ask people and apply. Come seek me or other surgeons as mentors. We can tell you how we did it. But don't let monetary reasons be a factor not to do it. I didn't have any money. You just have to take out a lot of debt. But it's okay. You can pay it back. Yeah. Oh, and the other thing is, don't be afraid of failing. I know you hear people say that all the time, but I stumbled and failed many times on my path. First year of college, I failed calculus the first time. And I thought that was the end of the world, and that was going to be the end of me. But I retook it, and I did okay. And so even if you fail a class, you can retake the class and keep going. Don't drop out or give up. As long as you keep getting back up and pushing forward, you'll keep edging your way along. And you just keep staying. And the other thing is, when you start this journey, it's going to look so far away, you're going to think that it's never going to end. And you just say, wow, if I could just finish all this, I would be done and finally be a surgeon. But then all of a sudden, one day it was over with. And now I look back and I go, I can't even believe I went through all that. I'm not even sure I really went to college or not, but I guess it happened. It goes so short in retrospect. But you really can do whatever you want if you're willing to put in the time and take out massive loans. But they can be paid back, right? So
Absolutely. I want to thank DHR Health and particularly Dr. Skoobish for being here today. And I also want to take the time to ask students that are listening in to go to our website and to email us any questions that you may have. Because what we want to be able to do is answer your questions and make sure that you got what you needed from this session. I know that a lot of times when we have interviewers, we're able to do live sessions, but what we want to be able to do is still answer your questions and get back to you as soon as we can. I also want to say that it was really refreshing to hear a lot of your personal story regarding the journey of you becoming a doctor, because I think that in my generation at least, and I know that we've heard from students, there's a lot of roadblocks, and initially when you hit the first roadblock, your first I guess like your first reaction is to say, okay, that's not going to work. You know, it's too long, 16 years. But I think that hearing stories like yours makes it very real for our students and inspires them to know that it is possible. And I particularly like the fact that you learned another language and you went to another country to offer your services. I think that that's amazing. So thank you so much for that. Again, students, thank you for joining us today. And as always, we'd like to thank our partners here at DHR Health for always accommodating and serving their community. Thank you.
Hi students, it's with great pleasure that I stand before you. My name is Jose Angel Nava. I am the Interim Director for Respiratory Therapy at Doctors Hospital Renaissance. I am a registered respiratory therapist, and I have been a registered respiratory therapist for 13 years now. I was born and raised in Reynosa, Mexico, and I came over when I was 14 years old, right around the age that you guys have right now. As a young migrant student, I had a lot of aspirations on what I wanted to do. One of those was to choose a career. I know that you guys right now might be going through a lot of confusion and difficult times deciding what you want to do. I would advise you to always follow your heart and your desires in whatever it is that you want to do, so you can achieve the greatest that you can achieve. In my profession and the way that that I have gone about it, I have always strived to do the best for my patients, to do the best for my community. When I started, I was 21 years old as a therapist, and my specialty is in the neonatal intensive care unit, where we attend to all of the high-risk deliveries and the most delicate of patients. We have babies anywhere from 400 grams all the way to full term, and we have great success with them, always putting our patients first, like if they were our family. I have experience a lot of great stories of success for the Nicu. And like I said, if you follow your heart and if you follow your passion, you would always do a great job. And that's what I want to encourage you guys to do, to be able to choose a career that you like. For me, respiratory was introduced by a cousin of mine in a conversation that we had during a holiday gathering, and that's how I learned about respiratory. It is a great profession, and we range from neonatal, which is my specialty, all the way to adults in geriatrics. We handle all of the ventilatory needs for the patients. Right now, as you have experienced and heard, COVID has really shined the light into a respiratory profession. Now everybody's hearing about ventilators. Everybody is hearing about ventilatory support and respiratory issues, and that's where our expertise comes into play. Now, it took me about 4 years to complete my career. I did an associate's for liver arts, and then I did an associate's for respiratory care. Coming from a family that did not have a lot of income, I was able to afford my school with financial aid and some student loans, and that's how I was able to do it. Also, I had a 50% scholarship because I maintain a GPA greater than 3.0. And the hardest thing about the program, I would say, that I lived was just trying to survive financially in the day-to-day basis. Obviously, a lot of people that go through college experience the same things, and hopefully nowadays there's more programs and more help. And with your efforts, also, hopefully you receive grants and you receive more help. And right now is the time for you to focus in school so you can receive all of the aid possible, so you don't have to have a complicated college career. In my normal day-to-day, now as an interim director, I don't have patient care, but I do have a lot of responsibilities when it comes to staffing, when it comes to equipment, and when it comes to my knowledge on what is the best way to apply our career and be able to transfer that knowledge into the other therapists on what is the best action plan for any given scenario. I interact a lot with doctors, I interact a lot with nurses, and really every single person that works in healthcare, we interact together and we make a great team, all of us together. We are a great machine with a lot of gears and a very complex system, and everybody needs to do his part so we can get the best patient results. And the skills necessary for success in my profession is the ability to be able to adapt on the go to very different scenarios. We go from something very simple that would be a breathing treatment, and we can go into full cardiac arrest and a full-on resuscitation for a baby, for a pediatric, or for an adult patient. And that is one of the most difficult things to do, that in one split second you have to be ready and have all of your abilities and have the steady mind and the steady hands to be able to perform a full-on resuscitation on a patient. That includes the placement on advanced airway and cardiac compressions, and we do all of the range when it comes to the code that we are doing. We provide medications, we establish the airway, and we resuscitate the patient. And the ability to do that takes time and takes practice and takes a lot of reading. Everything that you are doing is based on all the learning that you do in college and high school, all of those are the basis to what are you going to perform at the bedside. It is very complex to do, but once you have the knowledge, it'll be just up to you to apply it and to stay calm and composed in the most difficult of situations. I have witnessed a lot of great stories, like I said, and I have been able to be part of people's lives and to be able to touch their families. It's a great honor, and I feel honored every single time that I show up to work. I feel honored to be able to be part of somebody's life in their times of most need. Me coming from Mexico, not knowing how to speak English, I can say that I have reached the goals that I wanted to reach, and I think that coming into this country with my family, we had a plan to do great things. And I want you guys to know that you guys can do great things. There's no limits to what you can do. There's no limits in your mind, and there's no limit in the possibilities of what you can achieve. If you guys are interested in the respiratory profession, there are different colleges that offer the respiratory career. South Texas College offers a respiratory program, and also UTB in Bronzeville also offers the same career. There's also now ways to be able to do my career online, where you get sponsored by a hospital and the hospital gives you your clinical experience. There is really a lot of opportunities, and the respiratory field is in really, really high demand, and I would like to see you guys as my co-workers. We are a premier hospital in the Valley, and we are very interested in educating people. I am the prime example of it. I came as a 21-year-old new graduate from college, and Doctors Hospital Renaissance took me by the hand with patience and with a lot of love and care, and took me through every single step, every year, trying to make me a better therapist so I could do better for the patients. And our hospital is great teaching and giving you all the tools necessary so you can grow in your profession. Doctors Hospital Renaissance here in Edinburgh, we are always with our doors open for you guys whenever you guys are ready, and if you want to look into the profession, you want to come and do a tour, we can always do anything to make sure that we give you the best possibility and the most exposure to what the career would be. Hi there, students. I just wanted to give you thanks for giving me some of your time. I hope that my words resonated in some of you, and we are more than happy to be able to have the opportunity to be in front of you, and hopefully we will see more of you in the future. Thank you.
Hello, PATH students. My name is Diana Castillo-Gauna, and I am the American Heart Association Training Center Coordinator here at DHR Health. Today, I'm here to speak to you about how to perform basic life support, or something you might know as CPR. So this is something very good to know, whether you're in the school setting or even now that you're at home. It is something very good for you to know because you never know when this might happen, okay? So I'm gonna go through each step, the basic steps for you to perform BLS, okay? So one of the very first things that you wanna make sure that you do is that you make sure that the scene is safe, right? We wanna make sure there's no spilled water, no electrical cords, nothing in your way that might cause harm to yourself, okay? So we'll approach our individual. We always wanna make sure that they are responsive, right? So we'll start off with, sir, hey, are you okay? There's no response. So next what we do is we check for pulse and we also check for respirations. And we're doing that between 5 to 10 seconds, okay? So let's check for pulse and breathing. And this is something that you can do simultaneously. We are checking the carotid pulse as well as looking over and making sure there is no chest rise, okay? So once we are between those 5 to 10 seconds, we realize that there's no pulse, there's no breathing, so we want to call for help, you know. If there's somebody else with you in the room, somebody else with you at home, you tell them, hey, you, call 911, bring me an AED if you do have one at your facility, okay? So after we have called for help, we will automatically come to doing compressions. Now the compression rate for the adult is we want to do 30 compressions and then we will provide 2 breaths, okay? When we are doing our compressions, we want to make sure that we are going in 2 inches deep as well as in between 100 to 120 beats per minute, okay? So I'm going to demonstrate to you how we're doing compressions. So while I'm doing my compressions, you will see the blood flowing and you will see his forehead turn red, and this means that everything is being done correctly, okay? So I'm gonna go ahead and start my compressions. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 22, 23, 24, 25, 26, 27, 28, 29, 30. Okay, so here we are using a bag to give our breaths. So we are giving 2 breaths. We always want to make sure that we are tilting the head back to allow the breaths to go through. As soon as we're done with our breaths, we'll continue with compressions until help has arrived. 4, 5, 6, 7, 8, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 25, 26, 27, 28, 29, 30.
I know BLS. I will take over compressions. Here is the AED.
Thank you.
1, 2, 3, 4, 5.
So these are your
6,
AED
7,
pads.
11.
One will go up on this right side, right up on the top. And the other one will go right here on the side.
27, 28, 29, 30.
We will turn on the AED.
1, 2, 3, 4, 5, 6,
plug in the connector.
8, 9, 10.
Do not touch the patient. Stand clear.
Shock advised.
We will resume compressions until it's ready to charge. 4, 5, 6,
Stay clear
7,
of patient.
8,
Stand clear.
9. Everybody's clear?
Deliver shock now.
Everybody's
Press
clear?
the orange button now. Shock delivered.
I will resume compressions.
And then we automatically resume compressions until help is here.
5, 6.
So now we will cover the basic steps on how to perform CPR on a baby or on an infant. There are a couple of differences between performing these steps versus on an adult. One of the biggest differences here is that we are checking for the pulse at the brachial. So this is going to be the part in between the elbow and the armpit. So right here in between the arm is where we'll be checking for pulse. Right, so this is something we do check between 5 to 10 seconds. And another difference is how we check if they're responsive. On the adult, we kind of do pat them on the chest, right? Hey, are you okay? But on a baby, we are actually tapping their feet, right? This is where they're most sensitive as infants. So we kind of want to tap them, kind of tickle them, just to kind of stimulate them to see if they are responsive. Okay, so from the very beginning, we do make sure that the scene is safe. We make sure again that there's nothing around that's going to cause harm to ourselves, right? So we'll tap them, baby, are you okay? There's no response, so we'll be checking for pulse and we'll be checking for breathing for that chest elevation between 5 to 10 seconds. We see that there's no pulse, no breathing. We'll automatically shout for help. Hey, you, bring me the AED, call 911, and we'll automatically start with compressions. Now on a baby, compressions are done going in at a depth of 1.5 inches. So we can do this 1 or 2 ways. You can do it using your 2 fingers. So we'll do compressions this way, or we can also do it using our two thumbs, whatever's more comfortable for you, and this is what the thumbs would look like. Okay, I myself will be doing it with my thumbs as I do find that much easier. So on a baby, if you are by yourself, you are doing a compressions at the rate of 30 compressions and 2 breaths. Okay, so we'll go ahead and start that. Ready? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 26, 27, 28, 29, 30. So we will give our 2 breaths. Okay, another round of compressions. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. We'll give another 2 breaths using our barrier device. Once help has arrived, they will bring you what is an AED. As mentioned before, every AED is different. It comes with different instructions, but do not panic. All we have to do is simply turn on the AED, and it'll prompt you with directions.
Apply pads to patient's bare chest. Plug in pads connector next to flashing
So on an infant, we are putting the pads right in the center in the middle.
Apply pads. Plug
We
in
will turn the
connector.
baby over, and we'll put one right in the back in the middle.
Analyzing heart rhythm. Do not touch the patient.
Stay clear. We want to make sure that nobody is touching the patient while the AED is analyzing.
Shock advised. Charging. Stay clear of patient.
Stay clear.
Deliver shock now. Press the orange button now.
Everybody is clear. We'll go ahead and press the shock button.
Shock delivered. Begin CPR.
And we will resume with compressions. So we will do this until help has arrived. Once EMS or paramedics do arrive, they will take over. And thank you for joining me on how to perform BLS on both an adult and an infant. And just a few reminders, we know that sometimes out in the real world, we don't carry those barrier devices. You know, when you are giving breaths to another individual, we don't want those diseases or germs spreading. So we do ask that if you don't know the individual, if they're not your family members, we just really recommend that we don't give the breaths. What we recommend is that you do 5 cycles of the compressions, and after your 5 cycles, you will check for a pulse. If there's still no pulse, you will continue with compressions until help arrives. Another thing that I know that does make us very nervous is how to use an AED. What I can recommend is always to turn on your AED first, and the AED will give you exact directions and the steps to follow. And that is all here for the adult BLS CPR.
Hi, good afternoon. My name is Yvette Alanis. I'm a RN here at DHR. Just a reminder, this is a live segment where you'll have the opportunity to ask questions. I will answer questions after I share with you a little bit about myself and my career here at DHR Health. Feel free to submit any questions you have brought throughout my presentation. You can submit those by going to www.menti.com and using the access code 8378283. So my name is Yvette Alanis. I'm excited to be here, being able to speak on behalf of DHR Neuro ICU and the nursing profession. I am from McAllen, Texas. I've been a nurse for 11 years. I started in cardiac ICU, proceeded with medical ICU, then to neuroscience ICU. I have been a nurse, a bedside nurse, and a charge nurse, and now a clinical coordinator. I have been in healthcare since 2003. I never imagined being a nurse, only after becoming a paramedic. I took the paramedic to RN transition at So my path to becoming a nurse was, I attended South Tech College in McAllen. My paramedic took from school was 2 to 3 years, and then another 2 years for the RN program. I worked as a paramedic for a few years before going to the nursing program. I used student loans to pay off my schooling, and I worked part-time to pay for school. The hardest part of school was nursing school itself, because it ensures we understand the topics in hand and skills needed to care for real-life patients. A day in my shoes before becoming a clinical coordinator, it was in neuro ICU, was obtaining a report from the night shift. In neuro ICU, we review every system of the body, lab values, blood pressures, IV infusions, drains, and of course the patients. Doctors would round to review all the vitals, medications, a ventilator. We would manage drains. We obtain orders from the doctor, then carry out so the patient can get better. We continue to monitor the patient closely for changes in the ICU. Once stabilized, the patient would transfer out of the ICU. In neuro ICU, we would see patients with strokes, hemorrhagic strokes, which means bleeding in the brain, traumas, seizures, patients on ventilators, drains, and pretty much we would care for all types of ICU patients. Being an ICU nurse, we manage all types of patients. And now as a clinical coordinator, I oversee all the ICUs, including the cardiac, surgical, which is medical, and including the step-down units. We look at patients ready to transfer to the floors, and to ensure that all nurses are following our hospital policies. Other professions that we interact with in the ICU, which make a vital impact for our patients, are PT, physical therapy, occupational therapy, dietitians, pharmacists, case managers, social workers, chaplains, who are an important part of our care for the patient. Different doctors that do manage the patients in ICU is pretty much a lot of doctors, including trauma, cardiac, and wound care doctors. The skills needed for becoming here in the ICU is being an RN first. And of course, learning the ICU is learning in the ICU, and which includes how to manage blood pressures, drains, ventilators, which are all learned in the ICU. And of course, at home, it'll be a lot of home teaching yourself to be able to understand what's going on in the ICUs. Learning is never ending. The fun fact about neuro ICU and being a nurse is being a rewarding profession as you continue your education. The types of drains we have in neuro ICU is presented there, a picture. So patients can come in with bleeding in the head or high pressures. So there are different types of monitoring systems that patients can get for the brain, depending what kind of injury or fluids or blood is in the patient. And that's how we monitor the pressures in the brain in the ICU for these type of patients. What to look for in a stroke patient is another thing that we do in neuro ICU, is looking for the following, which is how to spot a stroke. We use the acronym FAST, first being face, which is a drooping, the arm, the weakness, the speech, which is having difficulty talking, and it's about time, which is calling 911. Time is brain. The sooner the better to get them to the hospital. The following is the equipment used to care for ICU patients. As you can see there, as an ICU nurse, we manage these type of patients with all these types of monitors, which is heart monitor, IV pumps, blood transfusions, hemodialysis. And sometimes with this machine is able to do dialysis on a slower pace for patients who are unstable to get regular dialysis. So all these is types of equipment that we manage in the ICU. Helpful tips is always keep learning outside of school. Look into different programs available in colleges. If you're passionate, don't give up. Take prerequisites that you can take now, the less to take in college. Skills needed to be successful is determination and passion. Take courses that will help you with skills on how to care for patients and be hands-on. The advice I can give myself when I was younger self with the start of my career was be patient. It will get better. Any questions? Let me check here. Okay, the first question is, what is the longest time you spent in a hospital? What made you want to become a nurse? Is it worth to be what you are now? Is the night shift easier or harder than day shift? The longest time you spent in a hospital. DHR has been my longest employer. I'm working for them. I've been here for almost 9 years. Not the type that move around a lot of works. So I've been passionate working here at DHR. I became a nurse after working as a paramedic. I worked as a paramedic since 2003, and then I proceeded to become a nurse in 2009, 2010. Because of the paramedic, it was an amazing opportunity, but I think there was more for me. So I was striving for more opportunities as a nurse. That's what I strive for. And then in the ICU, as I started a new nurse, which is very difficult, even as a paramedic, was very hard. But it was very difficult. But I am here now as a clinical coordinator, so all things are possible. Is it worth to be what you are now? Yes, it is. There's times it's difficult, but we do at the end of the day is for our patients. Night shift can be a little bit easier because there's not as many people or doctors, but you have to have that critical thinking at nighttime because if something happens, you need to know what to do next to care for your patients. Very good. Do we deal with COVID patients in the ICU? Yes, we do. In the beginning, we dealt with COVID. We separated from the main hospital, and we separated to the outside to care for just COVID. And we do have patients who require maybe like special monitors like a pacemaker, a balloon pump from cardiac ICU. So we have to take measures in the main hospital to provide care for COVID patients. That's meaning putting the N95, the masks, the full gowns, and they have to be in a strict isolation in that certain room. At first, it was very challenging, but it's gotten a little bit easier, but still we do deal with patients in the ICU. What do you do when the surgeon has to use the restroom? Are they able to take a break and leave the room? The surgeon does come to do bedside procedures. No, he doesn't take a break. He's able to finish his procedure at bedside. Let's see. I'm trying to manage this real quick, guys. There's questions, but I'm trying to go back. It kicks out the old questions out. Do you monitor both the patient and the surgeon? We do, yes. We do monitor the patient and the surgeon when they're doing bedside procedures. What is the biggest moment that has happened to you in your job? Miracles happen. Some patients who become very sick are able to pull it out from being very sick. It takes a long time to recuperate. Have you ever dealt with guilt with patients? No, because guilt with patients, no, because we're here to help them. It's very difficult, especially with COVID. We have to be with them. We are with them at bedside, and we're there as family to deal with their sickness while they're at the hospital. As a clinical coordinator, what I do is oversee all the ICUs. So pretty much if patients are able to go to the floor from the ICU, they graduated from the ICU, they've gotten better, they can continue the care. We make sure that our policies, our core measures for like stroke, heart failure, chest pain are all up to par to make sure everything is to standards. When it comes to two people in the OR, how do you determine who to work on first? This is a question for a surgeon, but most of the time the surgeons do proceed who is critical. They also have a backup surgeon who can care for the patient if they're both sick. So they'll call the backup. They usually have a surgeon and a number 2 surgeon. And I don't work in the OR. Sometimes we do take patients there in emergent, but we don't work in the OR. Would you recommend for someone who is an RN to go to ICU? Yes, no, but I did it when I was young. When I first started, I was a paramedic, but even as a paramedic, it was very difficult. If you have a good school that helps you do hands-on skills, that would help you. And if you're going to be determined to work, to learn outside of the ICU, outside from work, it will help you a lot to benefit to further your knowledge in the ICU, so you won't be afraid. What other career options do you have as an RN in the ICU? We have several. We have charge nurses. We have nurses who do procedures. We have different types of ICUs, surgical ICU nurses, which is they manage patients with trauma, surgical patients. You have your, which is where I came from, neuro ICU, patients with strokes. You have your cardiac ICU, being able to recover open hearts, patients who need pacemakers. How many patients do you have at a time? Depending how severe, how critical they are, we have a ratio of a nurse to 2 patients, or if they're really sick or they're like an open heart, is to one nurse to 1 patient. Do I ever wish to be a surgeon? No. So I can go home and sleep. They're always on call, always at the hospital. Are you thinking of staying as a paramedic or planning to do another type of job? Unfortunately, my paramedic license expired last year. I forgot to renew it. So I'm planning to stay as a nurse from now on. And as a clinical coordinator, there are other career options, which is escalate, going up to manager or director or assistant CNO to CNO, which is a chief nurse officer. Are you thinking, as an ICU nurse, can you work anywhere else? Yes. Anywhere you can dream, you can travel. Different specialties require, ask for nurses, other big hospitals. So we are very needed right now, so pretty much they can hire any nurse. ICU nurses especially are very high commodity. What was one experience that changed you as a nurse? the patients show me a lot, that things, patients themselves, in general, I think, have changed me as a nurse. They've taught me a lot how to care for them and family, to be able to be more passionate and more understanding of where they come from. How does your family feel about your profession? My family has been very supportive. My parents have been supportive when I was a paramedic, and now my husband. So they understand my job. It's pretty difficult. Many times they don't know what I go through, because we don't say anything when we get home. It's just pretty much go home and sleep. But it's a very rewarding job. What is the best quality you have as a nurse? I think compassion and caring for your patients. Do you plan on getting more education? Yes, I do. I'm actually in the works of getting my bachelor's degree. You can still work as an ICU nurse, as an ADN, but people take different routes in life and take their time. Some have progressed to becoming nurse practitioners. Now they're offering doctorate of nursing. So don't ever stop going to school, no matter if it takes you one course at a time. What has been the most troubling situation you have been in? Troubling. I do not have a answer for that one. Have you had any patients die? Yes, we have. Some have been because the patients do not recover from their illness, and others because of the patient's wishes or the family. And so we learn how to manage patients caring when they do that route for comfort. It's not very easy the very first time to deal with it, but at the end, we learn to know that it's the patient's or family's wishes and the dignity for the patient. Have you ever thought of being a travel nurse? Yes, I have, even now, but if I wasn't married or have a family, I would have, but my need is here in the hospital. We're able to manage what's going on here. And traveling is having to relocate somewhere, a new location, which is kind of hard for me. Other people have done it without a problem. It's just how they're able to manage being able to move and travel. But it's also very rewarding because you can see a lot of areas you've never been, states and cities. How do I deal with family? It's a learned process. You have to be patient because a lot of times it's being calm and hearing them and listening to them. It's just a matter that a lot of families are having a difficulty understanding the disease of the patients going through in the hospital, and understanding, listening, and to be able to deal with it. It just takes some time, and with that, we can find out what the issues are and to help it get resolved. Who has made the biggest impact in my life? I'm not sure. I'm not sure who's made the biggest impact. God. How do you make patients feel better when they have a bad outcome? Again, also listening to the patients themselves and families. Listening ears to, it's pretty much being there to listen to them. It makes them feel much better as well because there's somebody to talk to them and they're able to vent out the situations, whether it's a family, the patient, and they understand. You can see the caring, that we care for them. A few more minutes before we end the questions. So I'll be taking a few questions. Again, submit your questions. Go to menti.com and use the access code 837-828 and 3. Good questions. Again, thank you for having me today. Appreciate it. Y'all have a good day.
In this session, we are going to talk about careers in imaging services. My name is Maribel Tharp. I am the Assistant Director of Radiology here at DHR Health. So my path to becoming a radiologic technologist started many, many years ago. I did go to South Texas College, and it is a 2-year program. There are several prerequisites and co-requisites that come with the program. So those prerequisites you need to take beforehand in order for you to apply into the program. But if you have some extra time before the application deadline, then you can also take some of those co-requisites ahead of time and clear those out before. The program coursework itself is 2 years. So with those two combined, the program and the prerequisites, you're looking at about 3 years overall. With the tuition, as far as the overall amount and the quality, you would have to check with STC to see what the tuition costs are. However, there's so many opportunities to pay for your tuition, including financial aid, scholarships, and workforce solutions. In my experience, I didn't come from a home who was able to pay for tuition, so I came from a low-income family, and I qualified for financial aid. And during that, once I got accepted into the program, I heard about a lot of different programs, and I did a lot of homework. I Googled everywhere to be able to find the opportunities that were available to me as a student. And I came across Workforce Solutions. I went over there. I talked to someone, an advisor. They directed me in so many directions to apply for different things, and I qualified, and I was able to get that. So through Workforce Solutions, they paid for my tuition, they paid for some of my textbooks, a backpack, and even some school supplies at that time. So, it doesn't hurt to check in there, call Workforce Solutions, see what type of opportunities they have. And then during the program itself, I did get a lot of scholarships. I continued to apply for scholarships just for that extra support to make those ends meet and be able to pay for everything that I needed to. So a day in my shoes. Right now, I am an assistant director of radiology, but when I first graduated, that wasn't the case. I came on board as a radiologic technologist. I started working at a local hospital before coming into DHR Health as a surgery tech. I learned how to run the C-arm in surgery, helping surgeons locate areas so that they can conduct their surgical procedure. As a rad tech, you come in, you assess and verify the physician's orders for the exams, make sure the diagnosis correlates to the exam. For females of childbearing age, you want to make sure that there's no possibility of pregnancy. And if there's a contrast medium like iodine that they inject into the bloodstream, you want to make sure that the kidney functions safe. So there's a lot of things that you need to assess and consents that need to be filled out in order to make sure that the right procedure is being done for the patient. As a rad tech, you interact with multiple roles and departments, including physicians, the radiologists plus ordering physicians, the nurses from the nursing floor, from the emergency room, phlebotomists, respiratory techs, directors and administrators. They come around, checking for compliance, with the type of procedures, the cleanliness of the rooms, and some safety team members to make sure everything's working right with the fire safety, the fire extinguishers, and EVS personnel as well that come in between. Rad techs respond to code blues for X-ray, trauma codes for X-rays and CTs, and code strokes for CT. They also assist with CPR when it's needed, especially when it happens in your own department in radiology. As an assistant director of radiology now, I oversee staffing, productivity, employee development, handle a lot of employee compliance issues, make sure that they have their credentials up to date, interviewing and onboarding of new staff, take care of a lot of payroll, time cards and time off requests, approving for vacation time and holidays. I also handle development of presentations such as this and forms, policy forms or assessment forms for our patients. I handle employee issues and some disciplinary actions, and also take in and handle any physician or patient concerns that they have, good and bad. Some fun facts. So some fun facts for radiology. X-ray was actually developed by accident. William Conrad Röntgen discovered X-ray in November of 1895 when he accidentally X-rayed his wife's hand. So you'll see a lot of X-ray images if you Google it of a hand with a wedding ring or an engagement ring. And that was his wife's hand that he accidentally X-rayed. So from there, a lot of development has occurred. And now we have so many service lines in radiology. In 1927, 37% of radiologic technologists were nuns. Today, there are over 330,000 registered radiologic technologists. And one last fun fact, in observance of Breast Cancer Awareness Month, the first ever 3D mammography exam was performed in the US in 2011. And here you'll see some images of some of our imaging specialties. So on the left side, you see a regular, normal chest X-ray. And on the right side, you see an upper GI exam being performed under fluoroscopy. So you see the white part is the contrast that's going through the stomach, and the black that you see inside the stomach is the air in there. So you see how it's starting to go into the small bowel system. And here on this next slide, on the left side, you have a CT of the brain. So you are able to see that. What CT stands for is computed tomography. So it takes like slices, almost like a bread loaf, where it's cut into slices. So when it's scanning thousands of images into little slices like that. So there's a couple of slices that you can see there. So it helps the radiologist to visualize any hematomas, any blood in the brain, like for stroke patients. And on the right side, you see an example of an MRI of the lumbar spine. Down there towards the bottom, you see a black circle through the spinal cord, and that's a herniated disc that's bulging out there. You see some little, almost like fibers sticking down. Those are some of the nerves that are just being pinched there and are trying to get past the herniated disc. And just some helpful tips. If you are interested in radiology, there's just a few things that any medical professional needs. You have to have a huge interest in the medical field. And sometimes radiology is not a field that you think about when you think about the medical field. You think about nursing, you think about being a doctor. Those are two of the major things, but there's so many careers in the medical field. So do your research on that and look at different opportunities. In radiology, it's good to love to understand how things work because there's a lot of physics, and don't get scared by physics, trust me. I know I was, but you'll learn how to understand how X-ray is created and why the images come out the way they do and what you can do to make it better and fix the images. And passion. You have to have a strong passion to help care for people. You know, they don't want to be in the hospital. They don't want to go to the doctor's offices. I know I don't when I do. I don't want to be here. So you need to have that extra compassion and love for people in order to be able to do what you do here as a medical professional. So that is some of my tidbits and information, my pathway to becoming a radiologic technologist. I hope that it inspired some of you to look into this field a little bit further. And if you feel that this might be a career for you, feel free to contact me if you want more information, get more details. I know this is a short presentation, and I have 17 years, in radiology. So feel free to send me an email. There, my contact information is on the slide, m.tharp@dhr-rgv.com. Thank you all for your time, and I wish you the best in your future. Just remember that every choice you make now at this moment directs your path to where you go. So choose them wisely and take care. Best of luck.
Welcome, students. My name is Mark Gallegos, and I'm an exercise physiologist. I work here at DHR Health, Bariatric and Metabolic Institute. What got me interested in this profession was growing up, I was very much into sports, but lacking confidence. Exercise, fitness, it helped me build that confidence. With that increase and improvement in confidence, I wanted to help other people feel that same feeling of confidence that they may have been lacking prior. In order to get into this profession, you need to have a bachelor's degree, at least, in kinesiology or exercise science. A typical day working at this clinic, I'm educating patients on proper ways to correctly do exercises, as well as understanding body movements, body alignment, things like that. In order to be successful at this career, one definitely needs to have education and knowledge in exercise, but also compassion, sympathy, and also an ability to communicate that knowledge into the patients so that they can understand how to properly do things as well. Here at the Bariatric and Metabolic Institute, we deal mostly with patients that suffer from obesity. Here at the clinic, we have surgeons that do the bariatric procedures. We have dietitians as well that target the nutritional habits. We have a psychologist that targets anybody that may have any mental health issues, and then myself as well. So it's a well-run program that targets every aspect of obesity and how to improve these people's lives for the better. So in respect to my current position, since I am dealing with a lot of obese patients, many of them are very limited in their mobility, so we have to basically start from the very beginning, very basic, in order for them to kind of slowly climb to improving their mobility and also their flexibility, their endurance, and their strength as well. Working in this current position, it's been very rewarding. I see individuals walk in the doors with very little confidence to the point where they can't even look at themselves in the mirror. By the time they finish through the program, they have an increased confidence in themselves, then they're ready to tackle the world. For anybody that's interested in the career in exercise physiology or anything in that nature, you can definitely go to the University of Texas in Rio Grande Valley. There's a great program there in exercise science or kinesiology. And a bit of advice that I would give to you, yes, it is about exercise and it is about teaching people how to exercise, But it's one thing to teach them how to exercise, and it's another to teach them how to want to exercise. So you have to be able to motivate them and inspire them and make them feel like they want to exercise, as opposed to just teaching them how to exercise.
Good afternoon, everyone. My name is Nathan Dunn. I'm a physical therapist. Right now, I'd like to give you an idea of who a physical therapist is, what they do, the kind of equipment they use, and if you're interested in the career, how you become a physical therapist. So a physical therapist is an expert in the musculoskeletal system. We're movement experts. We spend a great deal of our training learning about the human body, learning the physiology, learning about the muscle groups, and so that we can apply it and help our patients. As a physical therapist, you may be using different pieces of equipment, and one that I have here today is an exoskeleton robot. Raymond is wearing the exoskeleton. It's going around his legs. He's wearing part of it as a backpack. There's a computer unit on the back side. Robots are becoming more of our way of life. We see them in a lot of different industries. We've seen them in the automotive industry. Now in healthcare, we're starting to see them a lot more. Robots are good for a lot of different reasons. One of the main reasons we'll use robots in any industry is because robots they're computers that can be automated. They can repeat actions that a lot of times a human cannot reproduce that same action at that same consistency. This type of device is called the EXO. It is only for physical therapists to use. He's not able to use this on his own. This one is only for training purposes, but we use it as physical therapists to help patients learn how to walk again. It's mainly for people who have difficulty walking. So think about someone who's had a spinal cord injury, maybe from a car crash, or they've had a stroke and they can't walk anymore. When they get in this device, it's automated in such a way that it helps them lift their leg up when they can't lift it. It helps them take that step when they can't take a step anymore. This is very handy in the clinic when we're working with patients. You might imagine someone who can't walk, if I'm trying to help them learn how to do that again, it takes a lot of effort on both parties, for the patient and also for the physical therapist. I might have to be lifting his leg or helping him balance. A lot of times that might cause me to be fatigued and I can't do as much training with the patient as necessary. In this robot, the patient can take many, many, many steps, and that's critical for recovery from a stroke, a spinal cord injury, or a lot of other illnesses that a person might have befall them. Like anything else in life, when we're learning how to do something, it takes repetition. When you learned how to play an instrument or play a sport, it took a lot of repetition. Sometimes that involved someone guiding you and telling you correctly how to do that. We've heard the phrase, perfect practice makes perfect. So this helps him practice perfectly how to walk. I'm going to give a little demonstration right now, and I'll show you how it looks when we're actually practicing. Okay, we're going to start with your right leg, Raymond. Ready? And step. Okay. Good. Lean to your left. There you go. Good. Good. Okay. Now bring your feet together. Okay, now lean back just a little bit. This device, we've had a lot of success with our patients. I've had a patient, a 15-year-old boy who was in a motor vehicle accident. He couldn't walk anymore after that. His legs were very uncoordinated. After using this device, he was able to walk again. He's able to run again. Another story we've had is a young lady, 25 years old, who had a rare neurological condition that left her legs paralyzed. With the assistance of the exoskeleton robot, and of course her doctors, her nurses, the other healthcare disciplines, she was able to come out walking and live her life as if she never had the illness before. So this is a great tool that we have that at our dispense as physical therapists. So the career of a physical therapist is a great career. It has so many opportunities for you as a clinician to work directly with patients. If you like working with patients, or if you think you might like working with them, this is one of the best careers you could choose. You have the opportunity to directly change someone's life if they've suffered some kind of injury and they're learning how to walk again. You're there helping them recover, and it's extremely satisfying knowing that you're able to help someone get back to doing the things that they used to love to do. To become a physical therapist, it does take quite a bit of time, a lot of schooling. After high school, you're looking at about 7 years total of schooling. That'll include undergraduate work. After undergraduate school, you would then apply to a physical therapy program. The program itself is at minimum 3 years long. To get into the physical therapy program, it's important you maintain a high GPA, really focus on your grades, especially on your science courses, biology, anatomy, physiology, chemistry. Those will help you look more competitive when you're looking to get admitted into physical therapy school. And it is a very competitive field. Classroom sizes in a physical therapy program are only about 40 to 50, and you may have over 400, 500 applicants. Also, having volunteer service always looks good on your resume when you're applying for college or for physical therapy. So look for ways, opportunities that you can volunteer for your community, maybe with a church or with a local group. That'll be an excellent way of showing that you're giving back to the community and that you're able to handle extracurricular activities in addition to your schoolwork. The admissions people that look at that, you'll be more competitive when you're ready to apply to physical therapy school. So I hope I've given you a little bit of insight as to what a physical therapist does, what kind of equipment they use, why it's a great career, and how to make yourself more competitive if you're considering a career in physical therapy. Thank you.
Hello, everyone. This is me, Dr. Kurtz again. I want to start by thanking Region 1 Service Center, who has been a great host in developing and supporting this conference with us. I truly want to say that we hope that you have had a great time with us today. DHR is always thrilled to have students like you joining us in expanding their knowledge of healthcare and what a career of this field may look like. After hearing from our healthcare heroes today, we really hope we sparkle your interest in joining them someday in the near future. Any advice? Don't hesitate to call us, to contact us, to go into our website, or even to go to the PATHS Conference website. You'll find lots and lots of information regarding healthcare professionals. I really wish you, and I wish in behalf of all of us, that you have a safe and successful ending of this academic year. Stay well. We'll see you next time. Thank you.
Thank you, everyone, and thank you to DHR Health and all of our fabulous presenters today. I'd also like to thank our participating school districts, Vanguard Academy and South Texas ISD. We hope you have enjoyed today's healthcare conference, and we encourage you to visit our website at www.pathcentral.org to get more information. In case you missed anything, we will be uploading the conference and we will be sending out links so everyone can send it out and enjoy. We hope you had a great day, and on behalf of Region 1 and DHR Health, again, thank you for joining us today. It's been a pleasure.